diagnose it and intimately identify the cause of patient symptoms. And muscle biopsy is valuable diagnostic tool for various muscle disorders. It can provide information about the structure, function, and metabolism of muscle fibers, as well as the presence of inflammation, deterioration, and the genetic abnormalities. Hence, is indispensable diagnostic for muscle diseases, especially when the cause is unknown, despite having done all the non-invasive procedures. To help us sharpen our skill and distinguish approaching muscle disease, our professor, who has a strong background in peripheral neuropathy, to share their insights and expertise with us today. And especially, we will be introducing the indication, contraindication, techniques, and interpretation of muscle biopsy for medical doctors and technicians. Distinguished guests, ladies and gentlemen, first of all, let's introduce our representative, Associate Professor Quốc, Acting President of the University of Medicine. Dr. Nguyễn Lê Trung Hiếu, Neurology Department, University of Medicine. Mr. Đặng Cao Cường, from the sponsor representative. And our organizing committee, Dr. Phan Đặng Anh Hương, Pathology Department, University of Medicine and Pharmacy at Dr. Phan Hoàng Phương Khanh, International Neurosurgery Hospital, and Dr. Lê Trí Sĩ, University Medical Center. Mr. Đặng Hoàng Minh, Senior Technician, Pathology Department, University of Medicine and Pharmacy at We are delighted to have two eminent professors with us today who will share their insight and expertise on neuromuscular disorders. Please join me in welcoming them in a round of applause. First, I would like to introduce Professor Ichizo Nishino, Head of the Department of Neuromuscular Research, Japan Center of Neurology and Psychiatry. Professor Nishino is a world-renowned authority on neuromuscular disease and enhance our knowledge treatment of this condition. It's a great honor and pleasure to have Professor Nishino join us today. Next, we have esteemed present of Associate Professor Umapathi, a senior consultant in the Department of Neurology at Singapore National Neuroscience Institute. Professor Uma, with his wealth experience in neurological disorders, has made remarkable strides in improving the quality and effectiveness of patient care. We are honored to have Professor Uma impart his invaluable wisdom to us. And to begin with, we are pleased to welcome Associate Professor Mo, who will deliver his opening speech right now. Yes, please, Professor.
Thank you, Dr. Thiện, and very welcome and good morning, Professor. Good morning, colleagues from across the countries to gather here to share the multidisciplinary approach for the very, very difficult challenges of disease. So before I begin my speech, very short speech, I will share personally, I will share myself about my experience, because basically I'm a pathologist, and I work here from very young when I graduated from UP, decided to become a pathologist. And during my training, most of the time, almost 20 years ago, most of the time, I was trained as a general pathologist. But when I become a senior pathologist,
I realized that many disease and tumor in general have to very like a subspecialties. So it needs to have subspecialty expert. So the second ones, I also learned about that for the challenging disease. We have to work as a team, like to practice the multidisciplinary approach, like neuromuscular disease. Today I am very happy to see pathologists, technicians, and clinicians, especially for the neurologists, but subspecialty for neuromuscular disease. Let me come back our my speech. Dear professors and Nishino, head of Department of Neuromuscular Research, Japan National Center of Neurology and Psychiatry, Professor Umapathi, Senior Consultant, Department of Neurology at the Singapore National Neuroscience Institute, dear on college. On behalf of University of Medicine and Pharmacy at Ho Chi Minh City, I warmly welcome to each and every of you for joining us today in this workshop. As Vice President of UMP, I'm honored to be to present at the workshop. I would like to begin by express my deep appreciation to the two professors for their heartfelt dedication and assistance in organizing this training session, and for every participant who has given their time and resources to participate in this session. As a pathologist, I understand in the intricate nature of muscle pathologies, which require a profound understanding of both clinicians and clinical and pathological aspects. Muscle disease encompasses a broad spectrum of conditions. It's presenting its own unique challenges and demanding specialized care. Today, I'm embarked on an extraordinary journey with the first ever workshop on the muscle biopsy and muscle disease. Our primary aim is foster collaboration, share knowledge, and cultivate empathy among the experts, researchers, healthcare professionals, patients, and their families. Together, we will navigate the intricate landscape of muscle disease and explore the newest advances in research, diagnosis, practice, and support team. I hope each participant will achieve immense value from this workshop. As we delve into the session full with knowledge, practice, exercise, and valuable tips to expand your understanding of the muscle disorders. Thank you for joining us today, and may this workshop will be the beginning of the transformative journeys through greater knowledge and support for muscle disorders. I wish the workshop success and see it as an important step forward in the future collaboration between the pathologists and neurologists within the field of muscle disorders. Thank you very much.
Thank you, Professor Ngô Quốc Đạt, for your inspiring speech. Now we have a rich, special moment where we have the privilege of presenting commemorative gift and flower to our esteemed professor. I would like to invite Professor Ngô Quốc Đạt to join us on stage to present gift and flower to Professor Nishino, Professor Uma, and Mr. Dan Cao Cường, our sponsors. Yes, please join us on stage.
So I think with your permission, I will, when we see patients tomorrow, we will be going through these approaches, clinical approaches, many times to understand how we approach clinical, how we clinically approach a patient with weakness. Okay? But today what I'm going to do is spend some time talking about how in countries like Vietnam and many of the places where we don't have all the resources, how we need to focus our attention to certain aspects of clinical medicine. Okay, so slightly different topic, but tomorrow we will be talking more in detail. Is that okay? Okay. So let me start off by, oh, the videos are now working. Many thoughts come to your head. Some of them are correct. Some of them may not be correct. So I always say that trying to solve a problem like this, weakness, is like trying to solve this. Okay? You can't solve this problem unless you have a formula. Right? In this formula, we will take this number, multiply by this, then you carry this number, and then as you are doing this, you come up with an answer. Correct? So in other words, you need a step-by-step formula. So weakness, we also have a formula. Okay? So we will approach the weakness today. Okay? So do you need to translate?
Em hỏi là gì là cái phần lâm sàng này có cần dịch không ạ? Chị trả lời em vấn đề em biết em còn làm. Dạ, thì như cái phần đầu thì có nói có nghĩa là khi mà tiếp cận một cái ca lâm sàng thì chúng ta nhìn quan sát người bệnh có những cái triệu chứng thì nó có vẻ là quan trọng, có những cái không, có cái đúng, có cái không. Thì muốn tiếp cận thì đầu tiên chúng ta phải đi theo một cái công thức. Ví dụ như là thầy có thực hiện một cái toán cách nhân đấy ạ, thì chúng ta phải đi theo cái công thức. Và khi tiếp cận một cái ca yếu thì chúng ta cũng phải đi theo một cái công thức, một cái cách thức tiếp cận chung như vậy, giống như là những gì mà thầy đã từng trình bày tại Việt Nam.
So in this formula, just like the mathematical formula, step 1, we decide is lower motor neuron or upper motor neuron.
Giống như là cái câu chuyện là mình làm toán đó, thì trong cái tiếp cận bệnh cơ thì đầu tiên là neuron rộng trên hay là dưới, cái bước đầu tiên.
Step 2, we decide whether it is, we decide what is the pattern of weakness, is it proximal or distal.
Bước thứ hai là chúng ta phải xem bệnh nhân yếu là cái yếu ngọn chi hay là gốc chi.
Then step 3, we decide whether there is sensory loss or not.
Bước thứ ba là chúng ta xem cảm giác có còn hay không, hay là đã giảm và mất cảm giác rồi.
And then the last step is if there is sensory loss, what is the pattern of sensory loss?
Và khi mà bệnh nhân có bất thường cảm giác thì chúng ta xem là cái hình thức mà bất thường cảm giác đó là gì.
Okay, so let's try this approach. So this is a patient who came to me many years ago complaining of weakness.
Đây là một cái ca bệnh mà tới với tôi đã khám nhiều năm về trước, tới với tôi vì bệnh nhân bị yếu.
So the first step is to use this 1, 2, 3, 4, 5 signs to decide whether it's lower or upper motor neuron.
Bước đầu tiên là chúng ta xem 5 cái dấu hiệu trên để quyết định xem là bệnh nhân này là neuron trên hay là neuron dưới.
So he had wasting, flaccid tone, absent clonus, hyporeflexia, and negative Babinski.
Đó là các cái dấu hiệu bệnh nhân có teo cơ hay không, trương lực cơ như thế nào, clonus ra sao, như trường hợp này là giảm phản xạ và Babinski âm.
So with that, we decided that he is lower motor neuron.
Tới đây thì chúng ta đã quyết định là bệnh nhân này là cái khu là neuron dưới rồi.
Next, we decide what is the pattern of weakness.
Bước tiếp theo là chúng ta xem là cái hình hai yếu là gì.
Can you decide, tell me what pattern of weakness is this?
Anh chị có thể cho tôi biết là cái hình hai yếu là gì hay không? Là góc chi hay mỏng chi?
So he can move this, but can't move this.
Cái gì xem cái tay, cái bàn tay thì
And he can't move the thighs,
di chuyển được.
but can move his feet. So it's proximal,
Dạ.
correct?
Đây có phải
So-
là-
Question number 2. Question number 1, lower motor neuron. Question number 2, proximal. Question number 3, sensory loss. He has got no numbness.
Trong trường hợp này thì cảm giác bình thường, không có tê.
So we have 3 possible diseases. It could be a myopathy.
Tới lúc này chúng ta có 3 cái khả năng rồi. Một là bệnh cơ này,
It could be a neuromuscular junction problem.
hai là cái vấn đề về tiếp hợp thần kinh cơ,
Or it could be motor neuron disease.
và cái thứ ba là bệnh nơ vận động.
Okay? All of them will look the same,
Ba cái nhóm này thì giống nhau, nhìn có vẻ giống nhau,
but they all have different features.
nhưng mà nó thực tế là nó sẽ có những cái đặc điểm giúp chúng ta có thể phân biệt được.
So this is just like here. All these animals have 4 legs.
Như cái bức tranh này các anh chị thấy tất cả các con vật này nó có 4 chân này,
They are found in Africa.
nhìn thấy được ở châu Phi này.
Many of them go together in groups.
và chúng sống trong bầy đàn này.
But if you want to recognize a zebra,
Nhưng mà làm sao để chúng ta biết được đây là cái con nào là con của bạn?
you need to know it's got black and white stripes.
Rõ ràng là mình phải nhìn vào những cái sọc trắng đen.
A giraffe, long neck.
Còn cái con vương cao cổ thì cái cổ nó phải dài.
So that is the key thing that you need to recognize, that although these 3 diseases look the same in terms of lower motor neuron, proximal weakness with normal sensation, each one of them have distinguishing characteristics, the so-called zebra stripe signs.
Đó là cái cách mà tôi đã quay lại bài thì để phân biệt ba cái nhóm bệnh này nhìn có vẻ giống nhau, nhưng mà chúng ta phải tìm ra các cái đặc điểm để phân biệt. Bởi vì cả ba cái nhóm này thì đều có những cái đặc điểm là nơ ở dưới yếu cơ, góc chi và cảm giác thì bình thường. Do vậy cái này tôi gọi nó là cái dấu của bạn hay là cái zebra stripe.
So in this patient, when we took off his clothes and asked him to stick out his tongue, we noticed that there were fasciculations.
Trường hợp này tôi cho bệnh nhân là thè lưỡi ra này, chúng ta thấy có cái fasciculation ở lưỡi này.
I had to shake here to show the fasciculations. But in the next video, you can see he has got fasciculations in the chest, in the neck, in the chin, in the tongue. All these suggest that this is
Trong các cái video này thì chúng ta thấy có cái fasciculation rung giật cái bó cơ này ở cằm, ở cổ, ở lưỡi, và những cái dấu này nó gợi ý cái gì vậy?
so fasciculations like this in the chin and in the tongue with wasting like this cannot be seen in myasthenia gravis, cannot be seen in myopathy, can only be seen in motor neuron disease.
Và với những cái dấu hiệu của fasciculation ở cằm, ở lưỡi, rồi có teo cơ thì nó là phải nghĩ nó không thể gặp, nó ít gặp trong cái bệnh liệt cơ, nó có gặp ở trong các cái bệnh cơ mà chúng ta chỉ gặp được trong cái nhóm bệnh gọi là bệnh nơ vận động.
So motor neuron disease, the most common type is amyotrophic lateral sclerosis. But then there are other types of motor neuron disorders.
Có rất nhiều các cái nhóm bệnh nơ vận động, ví dụ như là cái nhóm mà chúng ta hay gặp nhất là cái SMA chẳng hạn. Nhưng
So-
mà còn có những nhóm khác nữa.
Amyotrophic lateral sclerosis is a sporadic disease that is usually present in middle-aged to elderly patients. It is mixture of upper and lower motor neuron signs and progresses over 5 to 8 years.
Cái SMA thì nó hay khởi phát ở lứa tuổi trưởng thành. Nó cái tiến triển bệnh khoảng thì 5 năm đến 8 năm và nó có các cái dấu hiệu của cả nơ vận động trên và nơ vận động dưới.
Now this motor neuron disease on the other hand, there is a family history. There is a family history, number one. Number two, it's a very slowly progressive disease and it's only characterized by lower motor neuron signs.
Yes. Dạ, thì cái vừa rồi thầy chỉ mô tả về cái ca lâm sàng thôi, có tiền sử gia đình rồi tiến triển và nó chỉ có các dấu của nơ vận động dưới.
And this particular genetic disease is also characterized by a sex-linked genetic predisposition, sex-linked, and it's associated with hypoandrogenism, like for example gynecomastia, infertility, and other features of hypoandrogenism. Androgen.
Cái ca này thì thầy nói rồi một vài các cái đặc điểm, ví dụ như là nó có liên kết với những hệ nhân tính X và nó có cái liên quan tới cái giảm cái androgen, và trong cái trường hợp này thì mình có thấy là cái vật của bệnh nhân nam nó hơi to.
So this is Kennedy's disease.
Đây là cái bệnh Kennedy.
And I need to highlight this because a lot of times these patients, and I have done that also, if you don't recognize the fasciculations, you may mistake this for a myopathy. And if you biopsy the muscle, of course, the changes are neurogenic. But most interestingly, the creatine kinase for such patients, because of the chronic fasciculations, it's about 800 to about 1,000, usually slightly raised. So patients are often mistaken for limb girdle muscular dystrophy until you open the clothes and see that they have gynecomastia and they have fasciculations.
Có phải nhấn mạnh cái điều này bởi vì thật ra là những cái người bệnh này thì đôi khi tới thăm khám với bác sĩ, đôi khi thì các bác sĩ lại nghĩ đó là một cái bệnh cơ, bởi vì thật ra cái dấu hiệu mà fasciculation hay rung giật cái bó cơ ở những cái ca bệnh này thì nó rất là chronic, rất là mãn tính, thì đôi khi thì kể cả là kiểm tra trên lâm sàng hay là điện cơ thì nó cũng chỉ biểu hiện rất là nhẹ thôi. Do vậy nếu như mà chúng ta không có bộc lộ cái áo bệnh nhân ra, chúng ta không có quan sát cái dấu hiệu như thầy vừa mới chỉ là cái ngực nó lớn ở người đàn ông á, thì lúc này đôi khi chúng ta lại bị nhầm nó là cái bệnh cơ chứ không phải là bệnh vận động.
Then, of course, these patients, this is a patient in Myanmar, this is a patient in Pakistan, was shown to me because they were young men with lower motor neuron signs, proximal and distal, but mostly distal weakness with normal sensation.
Đây là một cái ca bệnh mà ở Pakistan và Myanmar tới thì yếu cả gốc chi ngọn chi, nơ vận động dưới yếu cả gốc chi và ngọn chi và cảm giác như bình thường.
But again, they have very prominent wasting of the tongue and fasciculations.
Cái ca này thì nó ưu thế là cái fasciculation ở lưỡi, tập teo lưỡi.
And like motor neuron, like Kennedy's disease, they also have prominent facial weakness.
Cái này nó giống như là Kennedy đúng không? Nhưng mà lại có cái yếu cơ ở mặt nữa.
And I noticed chin fasciculations too.
Và thấy luôn cả cái rung giật có cơ ở cằm nữa.
But they did not have gynecomastia.
Nhưng mà không có cái ngực to, không có cái ngực to.
And they also had deafness.
Nhưng mà cái ca này lại có một cái triệu chứng là ông bị điếc.
So these patients we thought belong to this group of motor neuron disease, which is more common in children, but can present in teenagers to adult doctors. So this is previously the name was these two diseases. They are both the same diseases described differently by different doctors. So there are two names. But now, because we know it's due to a riboflavin gene abnormality, we call it riboflavinopathy.
Dạ, thì đây là một cái ca bệnh nơ vận động mà nó cũng khá là đặc biệt. Nó có hai cái tên thì bây giờ thì người ta biết là những cái bệnh nhân này thì do cái thiếu hụt cái riboflavin, cho nên là bây giờ người ta xếp nó một cái nhóm là do cái thiếu hụt riboflavin.
So in these patients, if you suspect this disorder, you may consider doing the genetic test. But in these two patients, they couldn't afford the genetic test, so we tried a therapeutic trial of riboflavin.
Với những cái ca này á, nếu ở những cái nơi có điều kiện chúng ta phải làm gen, nhưng mà nếu không có cái gen thì như tôi nói rồi, cái bệnh nơ vận động này là do thiếu hụt riboflavin, do vậy những cái trường hợp những tân điển vậy chúng ta nên bắt đầu điều trị bằng cái riboflavin.
Okay, let's change gears again. Okay, another patient who presents with a low motor neuron, not much wasting, decreased tone, hyporeflexia, no clonus, no Babinski.
Đây, cái ca này là một cái ca của nơ dưới đây, các cái gì trên mà như thầy nói về trường hợp cơ không có clonus, không có Babinski.
His pattern of weakness was also proximal, and he had normal sensation. So again, the three differential diagnoses of motor neuron disease, neuromuscular junction disorder, okay, as well as myopathy.
Dạ, thì đây cũng vậy thôi, có ba cái chẩn đoán phân biệt bệnh cơ, tiếp hợp thần kinh cơ và neuron vận động.
Okay, so in this particular case, his zebra stripe was again not in his limbs but on his face, but he's got bilateral fatigable ptosis.
Ở đây là có gì cái vận giãn hai bên, và cái spleen hai bên.
Okay, so fatigable ptosis is an important sign to demonstrate because it tells you that this is a problem with the neuromuscular junction problem rather than weakness due to other causes.
Cái triệu chứng mà cái spleen mà do cái fatigable thì thực ra là phải lưu tâm, bởi vì nó gặp trong cái rối loạn cái tiếp hợp thần kinh cơ hơn ở những cái nhóm bệnh khác.
So remember, the patients with myopathy, patients with motor neuron disease, patients with stroke, patients with spinal cord disease, all of them, if you were to test their weak muscles, they were fatigued.
Những cái bệnh khác, ví dụ như là bệnh cơ, rồi bệnh neuron vận động hay là bệnh đột quỵ gì nữa, thì các cái cơ đó nếu mà yếu là nó yếu fatigue.
But what we need to do is go and test a muscle that normally does not rest. Normally does not rest. So in all of you, the muscles that don't normally rest are face, eyes, swallowing, chewing, breathing, and neck extension muscles.
Có một vài các cái nhóm cơ ở trên cơ thể chúng ta thì nó không bao giờ nó nghỉ hết. Ví dụ như là các cái cơ vùng mặt, nuốt hoặc là lưỡi, hoặc là các cái cơ vùng cổ, nhai, ốc, những cái cơ đó thì nó không bao giờ nó nghỉ hết.
So if you run a marathon at the end of 42 kilometers, most of you will feel a lot of fatigue in muscles of the legs, muscles of the arm, but your eyes are still open, face is still normal, swallowing is still normal, speaking is still normal, chewing is still normal, neck extension is still normal, and you're breathless but still can breathe normally. In fact, you are breathing heavier, correct? So these are muscles that normally do not fatigue even after 42 kilometers. So if you demonstrate fatigue in these muscles, then we know it's a neuromuscular junction problem.
Khi mà chúng ta chạy marathon khoảng cái 2 cây số thì các cái cơ đùi rồi cái cơ cánh tay của chúng ta sẽ rất là mệt, sẽ rất là mỏi, rất là fatigue. Nhưng mà thật ra chúng ta vẫn có thể mở mắt được, vẫn có thể nuốt được, vẫn có thể nhai được. Cái cơ ở cổ chúng ta vẫn có thể hoạt động, chúng ta vẫn thở được mặc dù là chúng ta khá là mệt. Thì những cái cơ đó thì nó không bao giờ nó bị fatigue, không bao giờ nó bị mệt. Nhưng mà nếu như một cái bệnh nhân ở những cái nhóm cơ mà không bao giờ mệt, mà vì chúng ta thấy là nó bị fatigue thì chắc chắn là cái bệnh lý ở đây là cái tiếp hợp thần kinh nó có vấn đề.
Okay, so how do we demonstrate fatigue? For example, this patient has got right-sided ptosis but abnormal eye movements. So we ask the patient to either look up or look to the side and wait for the eyelids to come down. Okay, so that's the normal way of demonstrating fatigue, either asking the patient to look up or look to the side.
Để mà minh họa cái fatigue hoặc là cái nhịp cơ mà nó cái cơ mà nó có fatigue thì rất đơn giản thôi. Ví dụ như spleen thì chúng ta cho bệnh nhân nhìn lên hoặc nhìn về một hướng,
Okay, then of course, putting some ice in a plastic bag and putting it over the ice for about 1 to 2 minutes until the ice become very cold. And then you take a picture after that, and if you see there's a lot of difference, that again is suggestive of neuromuscular junction problem. So it's a simple test called the ice pack test.
Để chị cho lại có cái test nước đá như thầy có làm đó, thầy có để cái test nước đá vào cái mắt bệnh nhân sau 1 đến 2 phút, và sau đó chúng ta lấy ra thì bệnh nhân đã hết sạch.
So remember, not everything that fatigues in your lid is myasthenia gravis.
Nhưng mà không phải cái gì mà nó liên quan tới cái lực sụp mi mà tại cái vi mắt nó đều là nhiều cơ cả, không phải tất cả như vậy.
For example, this is a girl that I saw in Pakistan.
Ví dụ như đây là một cái bệnh nhân nữ của tôi đã khám ở Pakistan.
So you can see the story here. She, at the age of, when she saw me, she's about 20 years old. But at the age of about 7 or 8 years old, she developed bilateral fatigable ptosis, ophthalmoplegia, swallowing problems, and proximal weakness.
Đó, thì cái bệnh sử như mọi người thấy có 20 tuổi thôi, nhưng mà 7 tuổi phổ tiến triển hàng loạt, khởi phát và tiến triển hàng loạt các cái triệu chứng như thầy có ghi ở trên bảng.
But because she had fatigable ptosis, a diagnosis of myasthenia gravis was made.
Và bởi vì là cái nhược cơ này nó liên quan tới cái phân tích, cho nên là lúc này khi chẩn đoán bệnh nhược cơ đặt ra.
Repetitive stimulation test was positive,
Và cái test kích thích lặp lại liên tục thì dương tính.
but acetylcholine receptor antibody was negative.
Nhưng mà khi làm kháng thể thì lại âm tính.
Okay, but nevertheless, they gave her steroids and pyridostigmine.
Nhưng mà do là vậy ở đó thì người ta cho cô ấy cái Biopsy, cái kháng men và cái steroid.
But she didn't get better.
Nhưng mà nó không có cải thiện gì cả.
So they decided to do a thymectomy,
Và sau đó là người ta quyết định là phẫu thuật cắt tiết ức
and she still didn't get better.
và cũng không tốt lên.
So she continued to get worse
Và cái triệu chứng này nó tiến triển nặng hơn.
on prednisolone and pyridostigmine.
Và tiếp tục vẫn được dùng cái prednisolone và pyridostigmine.
So she came to see me, and the clue was actually Dr. Nonaka taught me this long time ago. When you open a mouth and you see a palate is very high arched and very narrow.
Một cái tip mà tôi khi mà bệnh nhân này gặp tôi thì tôi cũng nhớ là giáo sư Nonaka đã từng chỉ cho tôi đó.
So, Dr.
Thấy là cái palate và cái vòm họng nó sẽ rất là cao, vòm họng nó sẽ rất là cao.
So Dr. Nonaka says that if you have to squat on the floor and look, because the patient's palate is so high that you can't, if I want to see your palate, if I just open your mouth, I can see it, right? But if I have to sit on the floor and then look like this, that means it's very, very high and narrow. And that's what happens here. You see, I had to really put the head down, and then only I can see, and it looks like a church spire.
Thì cái cách mà thầy Nonaka có dạy tôi là khi tôi phải quỳ xuống cái sàn nhà và tôi nhìn thì tôi thấy là cái palate nó rất là cao và rất là hẹp, và nó nhìn giống như là cái mái của cái nhà thờ vậy đó. Yeah.
So that tells us, once you see high arch palate, it means there must have been fairly static weakness very early, even before the age of 6 or 7. Maybe even when she was 2 to 3 years old, as the muscles are growing, she must have had mild, fairly static weakness that prevented her skeleton from growing normally. So she ends up with long, thin face and high arch palate.
Nhưng mà cái điều này khi mà tới cái đoạn 20 tuổi rồi mà đã thấy được cái triệu chứng này, thật ra là cái này nó rất là static, nó rất là tiến triển rất là chậm và nó rất là ổn định. Vì lúc đó thì cái mặt của bệnh nhân sẽ rất là dài đi kèm với các cái triệu chứng là cái vòng palate nó cao, vòng họng nó cao.
Okay, so this patient, that made us think that the story may be longer than 6 or 7 years. So we called the family members, and this is a sister.
Dạ, đây là cái chị gái, em gái.
Her younger sister, you notice, has similar long, thin face, mild ptosis, and milder version of her symptoms. In fact, another brother has got even milder symptoms. So we realized there was actually quite a significant family history, and the family history was also complicated by the consanguinity, that means they were getting married within family members.
Rõ ràng là khi kiểm tra các cái thành viên khác trong gia đình á, thì ít nhiều nó đều có các cái biểu hiện, có thể là mức độ nhẹ thôi, và sau đó thì chúng tôi có vẽ cái camera hệ ra xác định là nó có cái bất thường.
So then
liên quan tới di truyền.
we brought her to the electrophysiology laboratory and we confirmed that she indeed had decremental response on repetitive stimulation.
Dạ.
It's okay, please translate.
Có nghĩa là khi mà thầy có nói là bởi vì là khi mà chúng tôi làm lại một cái lab khác và chúng tôi thực hiện lại các cái thiết lặp lại liên tục như thế này.
But in addition to the decremental response, she also had after discharges.
Có nghĩa là cái phần decrement ấy, có nghĩa là cái giảm cái decrement khi
That means
mà thực hiện cái tác lặp lại
like this.
sau cái discharge, after discharge, sau cái phẫu thuật.
So she had decremental response, but also when she shocked the electrical discharge once, you notice that there is another discharge here, second one.
Có nghĩa là khi mà thực hiện lại một cái CMAP á, thì chúng tôi thấy một cái phẫu thuật khác nó đi sau lên một cái CMAP ở phía trước, một cái CMAP nhỏ đi sau.
So this combination of features made us suspect congenital myasthenic syndrome, especially the slow channel type.
Chính vì cái đặc điểm liệt cơ này mà chúng tôi nghĩ đây là một cái bệnh liệt cơ bẩm sinh.
And it's important to diagnose these conditions because these patients respond to other medications and may get worse on pyridostigmine.
Cái trường hợp này thì lại phải từng chẩn đoán đúng, bởi vì cái trường hợp này thì nó lại đáp ứng với các cái thuốc kháng nhưng mà khác, nhưng mà khi mà sử dụng pyridostigmine là cái thuốc mà để điều trị liệt cơ thì nó lại nặng hơn.
So just like so in this particular case, just like the earlier case, because we couldn't do genetic tests, we tried these medications.
Tương tự như cái ca lúc nãy, nếu mà chúng ta không có điều kiện làm gen á, thì chúng ta có thể bắt đầu điều trị bằng một số các cái thuốc như trên bảng.
Empirically, rather than in other places where we would actually do the genetic test to confirm it. But either way, these are conditions, these are medications that are cheap,
Những cái thuốc này thì rẻ,
very safe,
an toàn
and they'll make the patient better.
và làm cho bệnh nhân tốt hơn.
So we can't afford to miss this diagnosis.
Nhưng chúng ta rất là chú ý đến những cái chẩn đoán này. Cái em chỗ này em xin nói lại là cái lúc như nãy thì thầy có nói là làm cái lặp lại liên tục thì nó vẫn dương tính, nhưng mà khi mà thực hiện cái CMAP á, thì thấy có một cái CMAP đằng sau cái phẫu thuật đằng sau đi theo cái CMAP đó, thì đó là cái đặc điểm mà chúng ta nghĩ tới nhiều cơ bẩm sinh.
So remember, not all that flies is a bird.
Giống như là không phải tất cả con chim, tất cả các cái con có cánh đều là con chim.
Bats can fly,
Dơi cũng bơi được, bay được.
Superman can fly.
Yeah. Superman cũng bay được.
So just because the patient has fatigable ptosis doesn't mean it's always neuromuscular junction, an immunological acquired neuromuscular junction problem. It could be another form of neuromuscular junction problem which requires a different approach and different treatment.
Rõ ràng là bệnh nhân sực mi không phải là tất cả đều là nhịp cơ mắc phải, mà nó có thể là nhịp cơ bẩm sinh nữa, và do vậy cái cách thức tiếp cận điều trị sẽ khác.
So when I work in underserved areas, these are the clues that will make me think about congenital myasthenic syndrome.
Đây là những cái ca mà làm cho tôi nghĩ tới bệnh nhịp cơ bẩm sinh.
Very early onset, especially if it's present since birth. Very strong family history. A lot of them are autosomal dominant, so the family history is very useful. And early onset, as I said, high arch palate, long thin face, absence of antibody tests. Then the repetitive stimulation tests can be positive, but some be normal in some of them, and they may have after discharges.
Dạ, thì đây là những cái ca bệnh mà tôi nghĩ tới cái bệnh nhịp cơ bẩm sinh, bởi vì có các cái đặc điểm ví dụ như mỏng gao này, cái khuôn mặt dài này, khởi phát rất là sớm này, khi làm và đáp ứng kém với pyridostigmine là khi làm cái breath stim thì có thể là dương tính và cũng có thể bình thường, và khi làm cái CMAP thì nó phải có cái phóng lực ở phía sau cái CMAP.
This is another patient, you can see, long thin face, with high arch palate, also has got congenital myasthenia.
Ví dụ như cái ca bệnh này, cái mặt rất là dài.
And the last point is poor response to standard treatment. Steroids, IVIG, or plasma exchange, as well as pyridostigmine.
Những cái ca này thì đáp ứng rất là kém với các cái phương pháp điều trị chuẩn như steroid, như IVIG, như thái huyết tương, như là pyridostigmine.
So the next patient I think I saw last year in Hanoi. This is an elderly lady who presented with weakness, fatigable weakness of the lids. She also had proximal weakness, but very severe neck weakness and severe bulbar weakness.
Cái ca bệnh cuối là cái ca bệnh năm ngoái tôi có đi xem ở Hà Nội á, thì cái ca này yếu rất là rõ ở cái ngưỡng cổ và cái vòng cái cơ vùng họng.
She too didn't respond very well to steroids and pyridostigmine,
Cái ca bệnh đó thì cũng không đáp ứng tốt với steroid và pyridostigmine.
but she was an elderly lady with no family history.
Không có tiền sử gia đình, tuổi thì cũng lớn rồi.
Now her zebra stripe sign was again a lot of facial weakness, but also atrophy of facial muscles, which is not usually seen in standard myasthenia gravis.
Rõ ràng là đây là một cái ca mà mình thấy là cái teo của cái cơ mắt á, xung quanh mắt nó teo rất là nhiều. Nó không phải là quá điển hình của một cái bệnh liệt cơ điển hình.
Facial weakness is okay, but atrophy, muscles becoming thin on the face, it's rare in myasthenia.
Cái này là cái atrophy luôn, mà ở face có nghĩa là ở mặt á, thì cái này nó rất là hiếm trong những cái bệnh liệt cơ điển hình.
And if you look at the tongue, she also has got some mild wasting of the tongue, which again is unusual for standard myasthenia gravis.
Và khi chúng ta nhìn ra lưỡi thì cũng có teo nhẹ luôn, nó không có phải là điển hình của một cái bệnh liệt cơ điển hình.
And can you see that it's not just wasting like the ALS patient, but it's got an unusual wasting pattern where there are 3 lines like a trident.
Cái hình thái mà teo á, nó không giống như trong bệnh cơ. Rõ ràng là chúng ta thấy á, nó teo ở những cái rãnh và nó tạo thành một cái 3 cái rãnh, nó giống như cái cây đinh ba vậy đó.
So this combination of features in an elderly person, older person, female, severe neck weakness, severe bulbar weakness, mild ocular involvement, not responding to standard treatment, we have to think about MuSK antibody.
Một cái ca liệt cơ với những cái đặc điểm như tôi nói đó, có nghĩa là khởi phát muộn, rồi xong rồi là yếu cái cơ cổ, cái vùng hầu họng, rồi teo cái cơ mặt, rồi teo cơ lưỡi, rồi các dấu hiệu của ca đinh ba, thì chúng ta phải nghĩ tới cái bệnh liệt cơ liên quan tới kháng thể MOSK.
Why is it important? Because these patients, MuSK antibody patients, often respond better to plasma exchange and rituximab.
Bởi vì sao chúng ta phải nghĩ cái bệnh liệt cơ liên quan tới kháng thể MOSK, bởi vì nó chỉ có đáp ứng với thái huyết tương và rituximab.
So in this particular patient, again, she couldn't afford the MuSK antibody testing. So we empirically gave her rituximab. We actually gave her suggested plasma exchange, a series of plasma exchange to make her better, and then subsequently maintain her on rituximab.
Dạ, cái ca bệnh này thì sau đó thì đã đề nghị làm thêm cái kháng thể anti-MOSK và bệnh nhân được thái huyết tương, bệnh nhân dùng rituximab và hiện tại vẫn đang được duy trì bằng rituximab.
So I think these clinical signs that I've highlighted to you are very important for us because we work in a setting where many patients cannot afford standard testing. So all the more reason for us to be very careful with clinical examination.
Đây là cái lý do mà tôi nhấn mạnh ở cái bài, cái phần đầu tiên của bài, bởi vì không phải lúc nào chúng ta cũng có đầy đủ các cái phương tiện, ví dụ như là gen hay là cái gì đó mà chúng ta, do vậy là chúng ta phải cần hết sức là tập trung vào cái câu chuyện khám bệnh và cái kỹ năng lâm sàng.
So I've highlighted so far the importance of looking for fasciculations.
Nãy giờ thì tôi đã nhấn mạnh về cái fasciculation này.
Then in a case with Kennedy syndrome, the facial weakness, chin fasciculation, and gynecomastia.
Cái ca bệnh Kennedy đó, như tôi đã có trình bày lúc nãy, đặc biệt là cái đặc điểm là cái ngực to của đàn ông.
Then in the riboflavinopathy, it was the deafness.
Và một cái ca nữa là bệnh riboflavin.
And then-
liên quan tới cái điếc, có cái triệu chứng là điếc.
And then when you see fatigable weakness, remember to look for unusual features. For example, early onset family history, poor response, high arch palate that suggests congenital myasthenia, or one of the lesser common forms of immunological myasthenia like MuSK antibody myasthenia.
Và khi chúng ta xem xét các bệnh liên quan đến liệt cơ, thì ngoài cái bệnh liệt cơ chuẩn, chúng ta lưu ý tới các bệnh liệt cơ mà di truyền bẩm sinh và các cái bệnh liệt cơ liên quan tới kháng thể MOSK.
Finally, there's one more patient I want to show you, but unfortunately the video is not working. But I will describe the video, and maybe tomorrow I'll show it to you.
Còn một cái ca cuối thì tôi mô tả thôi để cái video nó không có hoạt động.
She was also a middle-aged lady who was admitted to the hospital for mild fatigable ptosis, very mild, but very severe limb weakness.
Cái ca này á, thì cái nhược cơ cái sụp mi nó nhẹ thôi, nhưng mà cái yếu cơ á, thì chi á, thì nó rất là rõ.
So again, lower motor neuron,
Cái ca này thì cũng là nơ đầu dưới.
proximal weakness with normal sensation.
Cái yếu cơ gốc chi cảm giác bình thường.
And because she had fatigable ptosis,
Bởi vì là có cái sụp mi mà theo kiểu fatigable,
no wasting, no fasciculations,
không có fasciculation, không có teo cơ.
the diagnosis was myasthenia gravis.
Vì vậy mà cái chẩn đoán là bệnh nhược cơ.
But what was unusual, which I'll show you in the video tomorrow, is that she had mild weakness of the limbs, but her reflexes were disproportionately lost. She had no reflexes in the limbs, even though her weakness is not so severe.
Có một cái triệu chứng khác á, là mặc dù bệnh nhân này có cái yếu cơ, nhưng mà nó lại có thêm một cái triệu chứng nữa là bệnh nhân bị giảm phản xạ nguy cơ cho dù ở những cái nhóm cơ mà không có teo.
And after a bit of exercise, the weakness,
Sau khi mà tập luyện, sau khi mà thực hiện cái exercise,
the reflexes returned.
thì cái phản xạ lại xuất hiện trở lại.
So what's the diagnosis?
Vậy thì chẩn đoán là gì?
So that patient had Lambert-Eaton myasthenic syndrome, which is characterized by very mild, the video is still not coming up, so tomorrow I'll show it to you.
Cái ca này thì chẩn đoán là hội chứng nhược cơ Lambert-Eaton.
Yeah, still not coming up, sorry. So tomorrow I'll show it to you. So when we exercised the patient, the reflexes came back. So she's got Lambert-Eaton myasthenic syndrome. So be careful, not everything that flies is a bird, not everything that fatigues is myasthenia. There are other diagnoses to consider.
Dạ. Cho nên cái điều mà tôi nhấn mạnh là không phải cái loài nào biết bay nó không phải chim, và không phải cái sực mi nào nó là bệnh nhược cơ chuẩn.
Okay, finally we come to the topic of today's workshop, which is myopathy.
Dạ. Và tới bây giờ chúng ta biết tới cái chủ đề chính là bệnh cơ.
It's important that we come to it finally because remember the patients don't come and say I've got weakness and I've got muscle disease. They'll just come and say I've got weakness, right? So we have to be systematic and make sure that we find lower motor neuron signs, proximal pattern of weakness, and then if there's nothing to suggest motor neuron disease, nothing to suggest neuromuscular junction problem, including the atypical forms that I mentioned, then we consider myopathies.
Tại sao mà tôi lại dẫn dắt cái bài như vậy? Bởi vì cái bệnh nhân mà tới các bạn không phải là tới một phát là bệnh cơ luôn, mà người ta tới với triệu chứng là yếu. Cho nên với bất kỳ một cái bệnh nhân yếu nào chúng ta phải tiếp cận như vậy cả, và chúng ta phải đi theo một cái công thức như vậy, và chúng ta phải loại trừ cái bệnh lý tích hợp thần kinh cơ, chúng ta phải loại trừ cái bệnh hô vận động, thì còn lại cái là cái bệnh cơ. Cho nên là lý do vì sao bây giờ chúng ta mới nói đến bệnh cơ.
So unlike the disorders we talked about, there are many types of muscle disorders. So it's best to organize it according to the pathological categories, the 6 pathological categories, okay, and then systematically think about them.
Khi mà tiếp cận bệnh cơ thì chúng ta phải tiếp cận theo nhóm nguyên nhân, và hiện tại thì nếu như tiếp cận các hệ thống thì chúng ta có 6 cái nhóm nguyên nhân như trên bảng.
Because like what Dr. Nishino said, some of these disorders will require genetic tests, some of them will require biopsy. Sometimes they may not need either one of the two, it's just clinical diagnosis.
Vì sao mà chúng ta phải tiếp cận hệ thống? Giống như là thầy Nishino đã nói, có những cái bệnh cần gen, có những cái bệnh cần sinh thiết, và có những bệnh cần chả cần gen, chả cần sinh thiết.
For example, this patient has got lower motor neuron, proximal and distal weakness, but in this particular case, he was complaining mainly of proximal weakness. Normal sensation, but his characteristic zebra stripe was not on his shirt, but on his hands.
Cái ca này là một cái ca mà chúng ta tiếp cận tới đoạn bệnh cơ rồi, bệnh nơ động vận dưới gốc chi cảm giác bình thường, nhưng mà tới cái đoạn này thì cái đặc điểm phân biệt cái ca này nó lại nằm ở cái bàn tay, chứ nó không phải nằm ở những cái vùng khác.
So you can see in a while, he has got myotonic dystrophy because when he squeezes his hands, he's unable to relax his hands.
Khi chúng ta khám, chúng ta cho bệnh nhân nắm tay và ông ấy rất là khó để có thể thư giãn được các cái cơ, các cái ngón tay.
And when you percuss the muscle, it will go into contraction and take very long to relax.
Hoặc là khi chúng ta gõ vào cái cơ trên tay á, thì nó bị construct, nó bị co rút và rất là khó để nó có thể relax được.
So in this particular condition, the clinical features are very characteristic, like what Dr. Nishino mentioned earlier. Facial weakness, bilateral ptosis, myotonia, electrical myotonia, but the pathology is very non-specific.
Nhưng mà cái ca này là cái ca mà như thầy Nishino đã nói đó, những cái đặc điểm như mà thầy vừa mô tả, và đặc biệt là cái triệu chứng mà cái cách khám của những cái ca myotonic dystrophy và những tơ tăng trương lực đó.
So that's why it's important to do a good clinical examination, good electrophysiology in patients before we decide which patients we want to biopsy.
Chính vì lý do đó cần phải khám lâm sàng thật chắc, rồi cái kỹ thuật điện, các cái kỹ thuật sinh lý điện cũng phải chắc trước khi chúng ta đưa ra quyết định là cái ca này có cần phải sinh thiết cơ hay không.
So in this particular case, the clinical and the electrophysiology was very diagnostic. Then of course you can confirm it with a genetic test.
Rõ ràng là cái ca này thì lâm sàng rồi sinh lý, làm điện sinh lý là nó đã có thể khẳng định được chẩn đoán rồi, và cái bước tiếp theo là chúng ta làm gen.
Likewise, this man, these features of this disease is also very, clinical features is very characteristic. The genetics is very characteristic, but the pathology is very non-specific.
Ví dụ như là cái ca bệnh này, đặc điểm lâm sàng sẽ rất đặc hiệu, đặc điểm về điện sinh lý cũng rất đặc hiệu, và gen cũng rất đặc hiệu, nhưng mà cái sinh thiết cơ thì lại không đặc hiệu.
So this is FSHD,
Đây là cái SSD, loại những cơ mặt tay vai bất kỳ.
where there is prominent facial weakness.
Cái yếu cơ ở vùng gốc như ở mặt.
But unlike the usual facial weakness, you must remember that the lower face is weaker than the upper face.
Nhưng mà các bạn có thể xem nó không giống như các cái loại những cơ khác. Cái mặt ở cái lower face, cái mặt phía dưới á, nó ảnh hưởng nhiều hơn cái upper face.
So if we just test the eyes alone, you may not recognize this disorder because you notice here, his facial muscles in the lower part of the body, lower part of the face are weaker, and actually his orbicularis oculi is not so weak.
Ví dụ như cái ca này nếu mà nhìn mắt không thì thấy nó không yếu gì hết, nhưng mà khi mà nhìn nửa mặt dưới thì thấy nó là yếu, tức là cái phần nửa mặt dưới nó là yếu hơn so với cái phần nửa mặt ở phía trên, các cái cờ nửa mặt ở phía trên.
Likewise, there is scapular winging.
Và ở đây nó có dấu scapular winging nữa.
But the scapular winging is unusual because I call this the curious scapula.
Nhưng mà cái dấu này nó cũng không phải là đặc hiệu là scapular winging, mà tôi gọi một cái dấu gọi là dấu curious scapular, hay là cái scapular tò mò.
Because when you lift up his arm, you notice that the scapula actually comes above the shoulder and looks in front and sees what is happening in front. So that I call it a curious scapula.
Khi cho tôi bệnh nhân khám đưa cái tay ra phía trước thì chúng ta thấy cái scapular nó đi ra phía trên và nó nhìn ra phía trước, cho nên là cái lý do đó khi mà khám lâm sàng thì tôi gọi đó là cái dấu curious scapular.
So facial, scapular, humeral because the biceps and triceps is weaker than the deltoid.
Vì sao và là humerus? Bởi vì cái cơ nhị đầu và tam đầu nó yếu hơn cái cơ delta.
So that again is very characteristic, and that's why sometimes you remember in textbooks they call it the polyhill sign.
Do lý do đó mà nếu mà các bạn đọc trong textbook thì người ta có dấu hiệu là polyhill signs.
So one hill is the scapula, the other one is the acromion, then next is the deltoid.
Thì đó là cái dấu polyhill như thầy có chỉ ở trên bảng, có 3 cái đồ.
So this again is a very characteristic zebra stripe sign for FSHD.
Đây là cái dấu đặc trưng của FSHD.
And likewise, just like some muscles are affected, some muscles are not affected. This in the abdominal muscles, the upper abdominal muscles are normal, lower abdominal muscles are affected. So when the person lies on that bed and does a sit up, the umbilicus goes up, and that is the BVO sign.
Rõ ràng là như tôi nói trong cái bệnh này thì có một số nhóm cơ bị ảnh hưởng, có một số nhóm cơ không bị ảnh hưởng. Ví dụ như khi chúng ta khám bụng thì các cái cơ ở bụng ở phía trên thì không bị ảnh hưởng, nhưng mà các cái cơ bụng bị ảnh hưởng, còn cơ bụng phía dưới thì không bị ảnh hưởng.
So
khi mà chúng ta cho bệnh nhân
so you can see here,
thì mình thấy cái rốn của bệnh nhân nó đi lên.
the umbilicus goes up.
Và khi mà cái rốn đi lên thì chúng ta gọi đó là cái dấu BY sign.
The umbilicus goes up, and so this is important. Now many of you will be saying, okay, so these signs are so clear cut, so it's easy to make diagnosis of FSHD. But I think all of us know that sometimes patients come to you with very clear cut signs. Sometimes they come with very subtle signs.
Rõ ràng là những cái bệnh nhân có những cái bệnh nhân đến tới thì có cái dấu hiệu nó rất là hiển nhiên, nhưng mà có những bệnh nhân tới thì nó rất là kín đáo, rất là khó để phát hiện được.
Like this man, who I saw, I think in, I can't remember which part of Vietnam. I think it's in, yes, Hanoi, many years ago, when he came with weakness, very thin, scapula was winging, but it wasn't very clearly curious.
Do cái ca này tới nè, cái scapular thì rõ rồi, nhưng mà cái dấu curious scapular thì nó lại không có rõ.
Okay? Then, but when we do the beaver sign, you notice, initially he doesn't want to move, but when we persuade him to move, you notice that the umbilicus will move.
Khi mà chúng ta kiểm tra cái dấu beaver, chúng ta ban đầu chúng ta thấy bệnh nhân cái rốn nó không đi lên, nhưng mà khi chúng ta thuyết phục cố gắng dịch chuyển đi, nhấc lên đi.
Okay, watch now.
Mọi người thấy không ạ? Cái rốn nó đi lên đó, dấu này là cái dấu hiệu beaver sign.
Do you see that?
Các anh chị thấy không ạ?
He's very weak, so he can't move, but when he moves, it umbilicus goes up. So that gave us the clue that is FSHD. And then in the other video, I'm not sure why it's not showing. So I think some of you may have seen it. Although the reason why they have a beaver sign is this muscle is normal, this is abnormal, right? Same reason why is the scapular winging unusual, because the upper trapezius muscle is relatively normal, the lower trapezius muscle is wasted. Correct? So here we couldn't demonstrate the curious scapula, but when we tested the upper trapezius muscle, it was stronger than the lower trapezius muscle. So that video, maybe tomorrow I'll bring it out and show it to you again. It's not playing on this particular presentation. But you saw the... Okay? You just give me a minute, see whether I can find it in the other... No. Okay. So anyway, there is another patient that I want to highlight to you. This I saw in Africa, Ghana. So again, maybe before we go to that, so another zebra stripe sign that's important is calf hypertrophy.
Một cái dấu hiệu nữa mà chúng ta cần phải quan tâm đó là cái calf hypertrophy.
So calf hypertrophy is a good sign in patients with, especially in young children, because in children, in young children, especially in infancy and maybe a little bit more than infancy, Duchenne muscular dystrophy is important, so calf hypertrophy is an important sign. But it's also seen in a few other conditions. But in this case, the diagnosis was apparent because of something else. Maybe you just explain this first, then I will.
Cái dấu mà calf hypertrophy có nghĩa là tăng phì đại bắp chân thì có thể thấy ở một số các cái bệnh nhi, ví dụ như là có thể thấy trong cái đoạn cơ Duchenne đó. Nhưng mà ở đây thì tôi nói là cái ca bệnh này thì chúng ta có thể tìm ra cái chẩn đoán dựa trên cha mẹ của đứa bé, chứ không phải là ở đứa bé này.
So I think Dr. Nishino may remember this case. Many years ago when we were in Sri Lanka, we saw this boy and he had proximal weakness, suggestive of myopathy, and because of calf hypertrophy, we were suspecting a dystrophinopathy. But as you know, calf hypertrophy can be seen in a number of conditions. But Dr. Nishino was very sharp. He wanted that sister who was pushing the wheelchair to lift up her skirt.
Cái ca bệnh này là cái ca mà tôi nhớ là thầy Nishino sẽ nhớ rõ, vì là cái ca này ban đầu thì chúng tôi nghĩ là một cái loại dưỡng cơ, nhưng mà sau đó thì thầy Nishino có yêu cầu.
And you can see the sister.
Và quan sát cái điều trị.
The sister has got asymmetric calf hypertrophy.
Và thấy một cái dấu hiệu là bất đối xứng của cái tăng phì đại bắp chân.
Which is very suggestive of a sex-linked disorder because the sister is asymptomatic. She's carrying one of the genes. So therefore, she has got some signs like this asymmetric calf hypertrophy. And that tells us that this must be sex-linked. So that made us more certain that we are dealing with dystrophinopathy rather than other causes of calf hypertrophy.
Trong cái trường hợp này khi mà thấy có cái dấu hiệu đó thì các thầy nghĩ rằng là đây khả năng cao là di truyền và liên kết với một sắc thể giới tính. Do vậy lúc đó thì thầy nghĩ nhiều tới cái nhóm dystrophin hơn là các cái nhóm khác mà có cái dấu hiệu giảm vaccine.
So this again highlights the importance of good clinical exam, not just of the patient but also the family members.
Nên là cái chỗ này thì thầy muốn nhấn mạnh là khi khám phải khám lâm sàng kiểm, không chỉ khám cho người bệnh mà khám cho các thành viên trong gia đình nữa.
Because the clinical sign, the zebra stripe, is not in the patient as himself, but in the sister. And this allows us to make a fairly good clinical diagnosis without the need for, I mean, of course, we have genetics, will be good. But in places where we don't have genetics, these are the signs that will help us decide that we are dealing with likely a genetic disorder of a sex-linked nature. And therefore, the most likely diagnosis here would be dystrophinopathy.
Rõ ràng là với những cái nơi mà chúng ta không có cái điều kiện làm gen thì cái việc khám lâm sàng rất là quan trọng. Thì trong cái trường hợp này thì cái zebra stripe nó không nằm ở bệnh nhân mà nằm ở cái sister, ở cái chị của cô ấy. Và rõ ràng là tới cái đoạn này thì chúng ta có thể đưa ra được cái chẩn đoán rồi mặc dù chúng ta không có cái phương tiện xét nghiệm gen ở đây.
So then there is a whole group of disorders called limb girdle muscular dystrophy, where the clinical signs are difficult to discern, but occasionally we are lucky. Actually, this one Dr. Nishino has published a bit more about it, so we'll ask his opinion. But I saw this patient in Ghana. Okay, he was a 32-year-old man who had history of weakness since the age of 16. Okay, and his CK was high, suggestive of a myopathy, but he had this very characteristic pattern of wasting of his shoulder girdle, suggestive of this particular sign, which is that looks like two heads of a calf on a trophy. You know, in the past when the imperialists were going around, they used to kill animals and put animals on the walls as trophies, right? So if you imagine if you take two bulls and you put it together, it's got this shape, right? And that shape is present in these patients with this particular form of limb girdle muscular dystrophy. So again, we thought we saw this same pattern in this man. And we also found something else that was very useful, which is the diamond in the muscle sign.
Đây là một cái ca bệnh mà thầy khám ở Ghana thì nãy giờ như thầy có mô tả, đây là một cái thầy đang nói cái nhóm bệnh gọi là limb-girdle muscular dystrophy.
So diamond in the muscle means as you are feeling that wasted muscle, suddenly you feel one localized swelling, looks like as if the person has buried a diamond inside his muscle. So it's called a diamond in the muscle sign. It suggests localized hypertrophy of the muscle, but in a very unusual way. So we found this in the same man. So with this combination, we thought again there was no genetics available in Ghana. So we made a diagnosis of dysferlinopathy.
Trong cái trường hợp này á, chúng ta nghĩ đến một cái bệnh mà như thầy có nêu trên dạng dysferlinopathy, có nghĩa là có những cái dấu lâm sàng, ví dụ như thầy nói là ở những cái chỗ mà loạn những cơ như vậy, cái cơ nó to như vậy, mình nhìn giống như cái cơ nó bị swell lên, nó phù lên.
So in the
nếu như mà chúng ta phát hiện ra những cái dấu như mà thầy vừa mô tả thì nó mặc dù nó không có gen nhưng mà chúng ta có thể ra được một, chúng ta có thể nghĩ tới cái dysferlinopathy giống như là cái trường hợp ca này ở Ghana.
So you see in the original paper, you can see in the wasted thigh muscles, there is a diamond here, right? So in this patient, in our patient, in the wasted deltoid, there was a diamond.
Ví dụ như trong cái trường hợp này, ví dụ như là cái cơ, rõ ràng là nó, cái cơ delta, cái tay nó rất là teo, nhưng mà tự nhiên chúng ta thấy có một cái khối nó nổi lên như vậy, cái khối swelling nó nổi lên như vậy. Hay là như cái trường hợp trong cái textbook trong thì mọi người thấy là cái đùi nó đang teo như vậy, nhưng mà sau đó nó có một cái ổ nó nổi lên như vậy.
So, but I think I'll ask Dr. Nishino to comment, because I think recently you published that it may be seen in other muscle disorders also, right?
It is called full business, so in French, so the fall in biceps right. I think the mechanism is the same.
But it's seen not just in 2B, is it? It's seen in other?
Well, I think after listening to your talk, I think the mechanism is the same. So it's like a diamond in biceps, it's called full business.
Sure, yeah.
But this is, well, actually, nobody is sure that whether that is very, very specific to dysferlinopathy or not, but many people believe that it's somehow specific to dysferlinopathy.
Sure. Okay. So again, these are useful signs when you are working in underserved areas. But of course, hopefully, eventually, we will get the genetics In this particular case, the genetics. In other patients, of course, the biopsy.
Thì như thầy nói á, có nghĩa là ngay cả cái nhóm gọi là limbogadal nó phức tạp như vậy, và thầy Nishino là một cái chuyên gia trong cái nhóm này, và thầy cũng đã có công bố những cái bài báo á. Thì thì thầy Uma có hỏi về cái comment là cái dấu này có thể xuất hiện những cái cơ khác hay không. Thì cái ý của cái phần này thì như thầy Uma mô tả là kể cả những cái nhóm mà nó khó như vậy, nó đặc hiệu như vậy, nhưng mà vẫn có những cái bệnh, nó vẫn có những cái dấu lâm sàng để giúp chúng ta định hướng được mà không cần tới các cái xét nghiệm chuyên biệt.
So, in other words, the first category of diseases, which are the genetic diseases, we thought the common ones to remember that we can make a clinical diagnosis, okay, are myotonic dystrophy, FSHD.
Cái nhóm thứ nhất mà tôi xin nói lại là những nhóm di truyền, thì đấy cho dù không có xét nghiệm gen chúng ta vẫn chẩn đoán được, như là cái loại chuyển cơ tăng trương lực hoặc là cái loại chuyển cơ mặt đai vai góc kỳ, không cần gen vẫn chẩn đoán được.
And then in the correct context of a young patient with sex-linked predominance, we can suspect dystrophinopathies.
Rồi cái tiếp theo là trong một cái bối cảnh, một cái ca bệnh cụ thể, ví dụ như cái ca bệnh ở Ghana thầy vừa mới nói á, thì chúng ta có thể có một cái nhóm gọi liên quan tới nhiều phát thể giới tính X, như là cái Myopathy như thầy vừa mới nêu ở trên.
So in these patients, it may be better for us to go straight to genetic test to confirm it and avoid the muscle biopsy, which could be non-specific.
Các chị nhớ là với cái nhóm này á, thì chúng ta đi thẳng tới gen luôn, chúng ta không có sinh thiết, bởi vì thật ra cái đặc điểm sinh thiết của nhóm này nó không có đặc hiệu, cho nên là với những nhóm này là đi thẳng tới xét nghiệm gen luôn.
But the large group of limb-girdle muscular dystrophies, the autosomal dominant and autosomal recessive types, very few of them have specific signs like dysvolinopathies. So you will end up doing a combination of biopsies and genetic tests to confirm their diagnosis.
Với cái nhóm mà limbogadal khác mà không liên quan tới những sắc thể giới tính X, ví dụ như di truyền trên những sắc thể thường, trội hoặc nặng á, thì nó lại phức tạp hơn, nó không có những cái dấu lâm sàng kiểu như vậy. Đôi khi tới lúc đó thì chúng ta phải kết hợp cả cái đặc điểm của gen và cả cái đặc điểm của sinh thiết để chúng ta đưa ra cái chẩn đoán xác định.
So inflammatory myopathies are very important because they are treatable causes.
Ví dụ như nhóm bệnh cơ do viêm là một cái nhóm mà chúng ta rất là lưu ý, bởi vì chúng có thể chữa được.
And I generally divide them into three big groups now.
Hiện tại thì phân chia thành 3 cái nhóm lớn.
The ones that are associated with systemic immune disorders,
Cái nhóm thứ nhất là nó liên quan tới cái rối loạn tự miễn hệ thống.
that like scleroderma, Sjogren's syndrome, lupus. Okay, so these are myositis associated with systemic immune diseases. It's very important to recognize them because muscle disease is a problem, but the systemic disease can be life-threatening. So we need to recognize that.
Cái nhóm thứ nhất là cái nhóm mà liên quan hệ thống như thầy nói đó, rất nhiều các cái bệnh như Sjogren, lupus, thì các cái nhóm này chúng ta cần phải quan tâm, chúng ta phải quan tâm đầu tiên bởi vì nó liên quan tới các rối loạn tự miễn hệ thống.
The second group of diseases are those that are associated with cancers.
Cái nhóm thứ hai thì nó liên quan tới ung thư.
So the classic prototype is dermatomyositis.
Cái phân loại cổ điển là viêm da cơ.
And again, dermatomyositis, although the pathology is also quite specific, the clinical signs are also very useful.
Trong cái viêm da cơ thì cái đặc điểm lâm sàng nó khá là đặc hiệu và khá là hữu ích.
And that is the purplish rash, not red rash, but purple rash.
Những cái ban màu tím, màu đỏ.
And the rash that goes around the eye,
Xung quanh mắt này.
not just over the nose, but around the eye, because the malar rash of lupus is around the nose, but in dermatomyositis it goes around the eye.
Dạ, trong cái viêm da cơ thì những cái rash đó nó sẽ xung quanh cái mắt này.
And then there are rashes in the hands, suggestive of what we call Groton's plaques. And then we have redness and small areas of skin infarcts in the nail beds.
Khi mà chúng ta quan sát cái móng tay á, thì nó sẽ có những cái mảng nó bị infarct rất là nhỏ thôi ở cái móng tay.
So, of course, it's good to make a diagnosis in this stage, but earlier you make diagnosis like what Dr. Nishino was saying earlier, the better the diagnosis is going to be. Sorry, just the slide just suddenly appeared. So, the earlier you make the diagnosis, the better the prognosis, especially when you're dealing with muscle weakness as well as cancers.
Cái vấn đề là với những cái nhóm này mà chúng ta tiếp cận chẩn đoán và đưa ra chẩn đoán càng sớm á, thì giống như thầy Nishino nói, nó sẽ tốt hơn rất là nhiều, đưa ra cái chiến lược điều trị phù hợp trước khi nó ảnh hưởng tới các cơ quan khác.
So, in this particular case, you can see that the patient, if you put a magnifying glass, okay, over the nail, you can see that the nail capillaries are not normal.
Khi mà chúng ta nhìn kính lúp, chúng ta khám rõ ràng là mình thấy cái tay, cái móng này, gần cái móng này nó có bất thường.
I think you can appreciate that there's what we refer to as telangiectasias in the nail bed.
Mình thấy những cái mảng telangiectasia ở gần cái phô á, móng
Okay,
tay.
so these are early signs of dermatomyositis, so very important to diagnose them.
Đây là cái dấu hiệu sớm của viêm da cơ.
Okay, so that is, of course, at this stage, there will be a lot of changes in the nail beds when it's very obvious Groton's plaques. But always, you know, you want to make a diagnosis in the early stages. So do look out for patients with very mild proximal weakness. And then the early stage of disease, if you find nail fold telangiectasias, that will make you suspect dermatomyositis or dermatomyositis-like illness.
Rõ ràng như tôi nói là cái việc chẩn đoán sớm cái nhóm bệnh này rất là quan trọng. Ví dụ như cái viêm da cơ, nếu như mà mình chẩn đoán sớm, mặc dù bệnh nhân chỉ có yếu nhẹ thôi, nhưng mà khi chúng ta khám kỹ, chúng ta phát hiện ra các cái mảng telangiectasia như thế này á, thì rõ ràng là chúng ta phải đưa ra cái chẩn đoán sớm là viêm da cơ hoặc là giống như là viêm da cơ.
Then of course, there are other skin changes that you would like to look out for. For example, if the patient has got skin that's very thickened, that looks like he's a farmer or a mechanic, then that again suggests that there is some sort of soft tissue, connective tissue problem that suggests a systemic disease like an anti-synthesis antibody-related disease, which is associated with other life-threatening complications like lung disease.
Ví dụ như là một số các cái triệu chứng lâm sàng các bệnh nhân tới khám, chúng ta khám thấy cái da tay nó rất là dày, giống như là bàn tay nông dân hoặc là thợ cơ khí gì đó, thì lúc đó thì đặt trong cái bối cảnh đó thì đôi khi chúng ta phải nghĩ đến các cái bệnh lý mà hệ thống khác chẳng hạn. Thì đó là một cái cách mà thầy muốn nhấn mạnh là cần phải rất là kỹ và tiếp cận sớm để đoán sớm.
Okay, perhaps to keep in the interest of time, I will not show you all the videos. Maybe we'll show you more over the next few days. Okay, or patients with what we refer to as mechanics hands, that would suggest that the patient has anti-synthesis antibody-related myositis, which is associated with interstitial lung disease also.
Ở đây tôi không có thời gian, nhưng mà có thể là tôi sẽ show cái video của người bệnh đó cho các bạn sau những cái triệu chứng lâm sàng của người bệnh đó tôi vừa mới nói, một cái bệnh cơ mà liên quan tới một cái kháng thể.
Okay, now then the last group of diseases that you must, the second and third and fourth group that you mustn't forget are endocrine disorders.
Một cái nhóm bệnh cơ nữa mà các bạn cần phải quan tâm có là liên quan tới nội tiết.
Obviously, again, if you muscle biopsy a patient with hyperthyroidism,
Các bạn nghĩ sao về cái sinh thiết cơ?
Like him.
Bệnh nhân mà
your pathology will be very non-specific, but his weakness is due to hyperthyroid myopathy. So the clinical diagnosis here will be more important than any specific biopsy or genetic test.
ví dụ như một cái bệnh cơ mà do tăng steroid, tăng cái hormone tuyến giáp chẳng hạn, thì các cái xét nghiệm như sinh thiết cơ hoặc là xét nghiệm khác thì nó không có đặc hiệu. Cho nên trong trường hợp này thì cái lâm sàng nó quan trọng hơn là cái câu chuyện là chúng ta đưa ra các cái xét nghiệm khác, kể cả sinh thiết cơ trong cái trường hợp nhóm bệnh cơ mà liên quan đến nội tiết, như trường hợp này là tăng cái thyroid.
Remember, both hyper and hypothyroidism can cause muscle weakness.
Các bạn nên nhớ là kể cả tăng hoặc giảm cái hormone tuyến giáp thì đều có thể gây ra bệnh cơ được.
And of course, we cannot forget drugs. We often remember steroids, we often remember statins, but we forget sometimes drugs that are like colchicine and some of the anti-hepatitis, antiviral drugs, you know, whether it's for HIV or for hepatitis. These are associated with myopathies. So always look through the patient's drug list, especially if it's a new drugs.
Các bạn nên nhớ một cái nhóm nữa ngoài cái nhóm nội tiết ra thì cái nhóm bệnh cơ liên quan tới thuốc, những cái thuốc mà các bạn đã biết, ví dụ như steroid tôi không nói, nhưng mà có những cái thuốc ví dụ như colchicine, hoặc là ví dụ như một số các thuốc mà điều trị viêm gan chẳng hạn, hoặc là một số thuốc mới, thì những cái thuốc đó nó vẫn có thể gây ra cái bệnh cơ, mà bệnh cơ đây là do thuốc.
So remember, we were saying that this is always an evolving field, so you must always look through. So for example, nowadays, a lot of cancer patients are on checkpoint inhibitors. So checkpoint inhibitors, as you know, can cause patients to develop an immune disease, like dermatomyositis, myositis, inflammatory myositis, or even disorders like myasthenia gravis. So it's very important that we look through a drug list to make sure it's not a iatrogenic cause due to something that we give the patient.
Cái ý này theo em hiểu là chúng ta phải khám người bệnh theo một cái hệ thống, một cách rất là hệ thống, để đôi khi có thể là những cái nhóm này nó sẽ dễ nhầm lẫn với nhau. Do vậy chúng ta phải khám một cách hết sức là chặt chẽ và có hệ thống để chúng ta quyết định là cái ca này nó có thể liên quan tới ung thư hay không, liên quan tới tự miễn hay không, hay là do các nguyên nhân khác. Bởi vì cái triệu chứng của các cái nhóm này đôi khi nó mix với nhau, mà nếu mà chúng ta không có khám một cách hệ thống thì đôi khi chúng ta lại bị nhầm.
So I think I've illustrated time and again the fallacy of a commonly approached recipe approach. You know, any muscle disease, you EMG, CK, muscle biopsy, genetics, and you try to get the diagnosis. So every patient gets all the 4 tests.
Các anh chị nhớ, với các cái cận lâm sàng dành cho bệnh cơ chúng ta có 4 cái test thôi. Thứ nhất là EMG điện cơ, thứ hai là cái CK, thứ ba là cái sinh thiết cơ, và thứ tư là gen. Đó là 4 cái xét nghiệm mà.
So I've illustrated to you that this approach is not going to be good. Not only is it expensive, but it's also going to lead you to wrong diagnosis many times.
Yeah. Sorry again.
It's not only is it expensive, this approach of doing all 4 like a recipe, every patient. Some people teach this kind of method, that anytime you suspect a muscle disease, you just do all the 4, and then when you do all the 4, you will find the answers.
Yeah.
But the problem is, firstly, it's very expensive. Secondly, you can often be misled.
Yeah.
Okay? For example, I showed you a case that of Kennedy's disease where the CK is high. Okay? I showed you a case of fatigable ptosis where the repetitive stimulation is abnormal, but it's a congenital myasthenia. Okay? And then we also showed you that patients with myotonic dystrophy, FSHD, okay, and even Duchenne muscular dystrophy, the biopsy may not be as useful as the clinical and genetic tests.
Rõ ràng là những cái thứ mà tôi nói đó, có nghĩa là nếu mà chúng ta thực hiện đầy đủ tất cả những cái thứ đó trong bệnh cơ thì tuyệt vời rồi, chúng ta ra được chẩn đoán. Nhưng cái vấn đề là không phải lúc nào những cái cơ sở hoặc là những cái nơi chúng ta làm việc là có đầy đủ tất cả các xét nghiệm như vậy. Cho nên cái cách thức tiếp cận ở đây nó cũng phải phù hợp. Mà như tôi nói đó, có thể là nhiều khi chúng ta xét nghiệm hoặc là chúng ta làm quá nhiều, chúng ta lại bị nhầm lẫn nữa cơ. Cho nên là cái cách tiếp cận ở đây là nên tiếp cận một cái cách thức bài bản và bắt đầu từ cái lâm sàng.
So we don't want any, we don't even want a 1% or 2% error rate, because the 1% is person, right? So we want to get it right 100% of the time. To get it right 100% of the time, just like mathematics, you need a formula.
Nãy giờ tôi nói với các bạn á, là khi chúng ta làm chẩn đoán cho bệnh nhân á, chúng ta không muốn là chẩn đoán chỉ có 1%, 2% thôi, mà chúng ta phải ra từ chẩn đoán là 100% chính xác. Mà muốn 100% chính xác là chúng ta phải tiếp cận một cách có hệ thống và theo công thức.
Okay, the formula is based on the fact that you decide whether it's low motor neuron, proximal or distal weakness, and abnormal sensation, and then you decide that there is possibly a muscle, neuromuscular junction, or motor neuron disease. And then you try to decide based on the zebra stripe which of the 3 is most likely. If it's neuromuscular junction, then you have to think about whether it's an acquired or genetic disease. Likewise, if it's motor neuron disease, is it an acquired or a genetic disease. Okay? After you've ruled this out, then you think about myopathies.
Cái cách thức tiếp cận hệ thống là gì? Tôi xin nhắc lại, vẫn là cái câu chuyện là nó vận động trên hay là dưới, yếu gốc chi hay ngọn chi, cảm giác bình thường hay bất thường. Cảm giác bình thường thì chúng ta có 3 nhóm là nơ vận động, bệnh tiếp hợp thần kinh cơ, bệnh cơ. Rồi sau đó chúng ta phải phân biệt 3 cái nhóm này. Trong cái nhóm tiếp hợp là thần kinh cơ thì cái nhóm nào là di truyền, nhóm nào là mắc phải. Trong cái nhóm nơ vận động thì nhóm nào là di truyền, nhóm nào là mắc phải. Và sau đó thì chúng ta được tới cái nhóm gọi là nhóm bệnh cơ.
And then if it is, once you've decided it's muscle disease, you know there are pathological categories: genetic, metabolic, endocrine, inflammatory, inflammatory mostly, neoplastic, paraneoplastic, and toxic human activity. So if you go through systematically and think in a young patient with family history, more likely genetic, then what are the common genetics? Myotonic dystrophy, FSHD, Duchenne muscular dystrophy, limb-girdle muscular dystrophy. So look for the specific signs. If it is an acquired disease, okay, especially there's no family history, then you have to look carefully for treatable disorders, endocrine, metabolic disorders, as well as drug-related causes, as well as inflammatory causes. And inflammatory causes very important to diagnose because not only is the muscle disease going to cause problem, but it could mean there is underlying cancer, number one, or it could mean that there is underlying inflammatory disorder that can kill the patient, like lung disease, kidney disease, lupus erythematosus. These are disorders that need to be diagnosed systematically. So that's why it's important to go through.
Tới cái đoạn bệnh cơ rồi á, thì cách tiếp cận là như thế nào? Chúng ta sẽ tiếp cận theo 5 nhóm. Thứ nhất là di truyền, thứ hai là nội tiết, thứ ba là viêm, thứ tư là nhiễm và thứ năm là cái nhóm liên quan tới thuốc. Ví dụ như một cái ca bệnh mà tới trẻ có tiền sử gia đình thì chúng ta có thể nghĩ tới các nguyên nhân di truyền, ví dụ như những cái ca bệnh mà tôi vừa mới trình như là một cái loạn dưỡng cơ tăng trung lực hoặc là một cái SHD, còn một cái ca bệnh mà tới với chúng ta mà cái lứa tuổi nó lớn hơn rồi cái cách thức khởi phát, chúng ta nghĩ nhiều tới các cái nhóm nguyên nhân mắc phải, thì chúng ta phải nghĩ tới cái nhóm có thể là do cái nội tiết hay không, do thuốc hay không, và quan trọng hơn một cái nhóm nữa là như tôi nói là cái nhóm viêm. Cái nhóm này chúng ta cũng phải cần nhận diện sớm, bởi vì cái vấn đề khi chúng ta nhận diện sớm thì chúng ta nên nhớ là nó có nhiều các cái vấn đề đằng sau đó, ví dụ như có liên quan tới ung thư hay không, chúng ta phải chữa ung thư, hoặc là liên quan tới viêm rồi thì thật ra nó đánh vào rất nhiều các cái cơ quan, các cái hệ thống khác, có thể bệnh nhân sẽ chết vì những cái vấn đề đó, ví dụ như là bệnh phổi hoặc bệnh thận chẳng hạn. Do vậy với cái nhóm này tiếp cận tới cái nhóm này thì chúng ta phải tiếp cận một cách hết sức là hệ thống.
Okay, so I'll stop here and take questions.
Dạ, thì cái bài của tôi tới đây là kết thúc, và bây giờ thì các anh chị có câu hỏi trên cái khía cạnh là một cái nhà lâm sàng tiếp cận một cái ca bệnh cơ như thế này. Xin mời các anh chị đặt câu hỏi.
One question. Thanks so much for your case and very interesting with your case. But I want to ask you one question for when we see a high arch blood balance and long phase. I remember that we can think myotonia congenita. So how we can differ congenital myasthenia gravis and myotonia congenita? Thank you.
Yeah, so I think I didn't show all the cases, but basically I think if you see a person with a muscle disorder that starts at a very young age, okay, then of course there are some disorders that you have to think about besides so I'll start again. So if you see a high arched palate and long thin face, it just means that the patient has been weak, relatively weak, okay, in the facial muscles, bulbar muscles, since a very young age. So of course it could be a muscle problem like a congenital myopathies. Like just now Dr. Nishino showed a central nuclear myopathy, right? So clinical features of central nuclear myopathy is characterized by onset of weakness since young, associated with long thin face and high arch palate, right? So that is a cause of patients with high arch palate. Now of course in congenital myasthenia also, because the weakness has been there since very young age, they can also have similar features. So it is not specific for congenital myasthenia, but it can be seen in a number of disorders. So again, you have to start thinking, is this muscle or neuromuscular junction problem? And then that's when the tests like creatine kinase, EMG, because myotonia, congenital myotonias or the congenital myopathies, you will have myopathic features. In congenital myasthenic syndromes, you may not have myopathic features, but you have repetitive stimulation test positive. Then of course finally the muscle biopsy. In congenital myasthenia, muscle biopsy is non-specific, but in congenital myopathy you will get the characteristic features, whether it's namelin rods, whether it's central nuclear or central core disease and things of that sort. Okay? So I think, as I said again, the importance is not to just think about one particular test. Important to start off clinical first, maximize the clinical output first, then maximize the electrophysiology, then maximize the value of creatine kinase. Then after that, think about muscle biopsy and genetics. If muscle biopsy we are suspicious of a disorder that is not characteristic in muscle biopsy, then you may want to go to genetics straight away. But otherwise, muscle biopsy is very useful because sometimes you may think it is a genetic disease, like the HMG-CR patients that that Dr. Nishino showed you, but it may be a treatable disease, inflammatory disease. So it is important to be systematic. All 4 of them, it's just like, when you are in the kitchen, you don't just use your spoon. You use your spoon, you use your knife, you use your fork, you use a big spoon, small spoon, right? You don't just cook with 1 or 2 things, right? So depending on what you need, you will take many tools. So here, don't be constrained by always using the same thing. Use all the tools available, but be very selective. How can you be selective? By relying on clinical skills.
Hiếu tóm tắt cái ý thôi ha. Thì Hiếu hỏi câu của thầy một câu là cái dấu hiệu mà vòm hầu cao cộng với lại cái khuôn mặt dài á, thì trên cái ca lâm sàng mà thầy trình bày thì nó hướng tới là bệnh nhược cơ bẩm sinh do căn nguyên di truyền. Tuy nhiên trên thực tế chúng ta thấy dấu hiệu đó thì chúng ta có thể nghĩ tới cái tình trạng là bệnh cơ tăng trương lực bẩm sinh vẫn có thể có một dấu hiệu như thế này như vậy. Nên hỏi thầy là làm sao để phân biệt. Thì theo cách trả lời chắc là các anh chị đã nắm được ý là cái dấu hiệu đó chỉ gợi ý là cái bệnh đã tiến triển từ rất là sớm, khởi phát từ rất là sớm thì người bệnh mới có những cái dấu hiệu như vậy. Thì trong tình huống đó thì chúng ta sẽ sử dụng tất cả các cái dữ liệu khác từ lâm sàng, điện cơ, một số trường hợp này có thể tới cả sinh thiết nữa để chúng ta có bằng chứng và phân biệt giữa các cái nhóm bệnh đó với nhau. Dạ, xin hết.
Okay, thank you, Professor, and it's a very nice lecture. And
Sure.
What I learned a lot from your lecture and Dr. Nishino, Professor Nishino also is we should be based very much in the clinical side. We should have something like a formula to reach out our diagnosis. And as you see, that is not also very simple. It's quite complicated even from clinical side as we are the clinician, but it's very useful. The question is, now we still have some very big problem in the clinical side that if we have to rule out some kind of diagnosis, and we need subclinical tests like EMG or the pathology, but sometimes the information from this test also very curious, because for example in clinical we think about some muscular dystrophy, but the information from the EMG and the pathology sometimes is the sign from myositis or something not very specific. So what is your recommendation?
Yeah, agreed. That's why I've been caught out many times by SIM. So for example, a patient presents with proximal weakness and the EMG shows myopathic features, but actually if you didn't do a repetitive stimulation test, okay, because if you think about it, I think in the lecture I've given to some of you guys on the motor unit potential. If the motor unit potentials between the muscle and neuromuscular junction in multiple muscle fibers are blocked, then the units are going to be almost like a myopathy. So you will get small early recruitment and you may think it's a myopathy, but actually it's a neuromuscular junction problem. But if you don't do the repetitive stimulation test properly, right, you would make an error. So that's why we don't suggest that electrophysiologists just do a test without any clinical examination. So clinical examination is important, so we are systematic. We make sure that the patient has got, in fact recently I saw a patient who had lower motor neuron, proximal weakness, okay, he denied sensory loss, completely denied sensory loss, okay. But of course we didn't believe him. When we tested him, there was some subtle sensory loss, okay. So we thought about a muscle disorder, but we couldn't rule out. If you look here, because he had subtle sensory loss, we have to think about, now where was my slide, one second. Huh? If you think about it, if you go on this side, if there is some sensory loss, then you are dealing with some form of demyelinating neuropathy. Okay? So the muscle biopsy was done even before we saw the patient. Okay? I think it was reasonable because the patient denied any sensory loss. But when you examine him carefully, there is some sensory abnormalities. Electrical testing, mild sensory abnormalities. Okay? Electrical testing, mild slowing. Mild slowing. Okay? So, the diagnosis of chronic inflammatory demyelinating polyneuropathy comes up. And of course, when you go and examine the patient carefully, he has got clubbing, he's got skin changes, he's got organomegaly, and he's got Poem syndrome. Okay? And the muscle biopsy was very non-specific. Okay? But it was done because it was proximal weakness. So again, the formula, if proximal weakness, muscle biopsy. Distal weakness, nerve biopsy. That kind of approach that sometimes is in the old school was advocated. I don't think it's a good idea. I think you have to really keep an open mind and always ask yourself whether you could be wrong, where you could be wrong, right? So EMG can be wrong because, for example, you can, in colchicine myopathy, you can get myotonic discharges, right? So I've seen patients who have been labeled as myotonic dystrophy. But when you examine the patient, there's nothing to suggest myotonic dystrophy. How can the electrophysiologist label it as myotonic? And if you take the history, you will say that, oh, the patient was well until he took some gout medication, developed some renal impairment, and then developed acute rhabdomyolysis, and he's got myotonia. So actually, none of these findings are on their own very useful, right? CK can be raised in Kennedy's, for example, correct? So therefore, I think you are right. It's difficult. It's difficult, and I think I've many cases of FSHD that I think clinically very obvious. But then when we have had patients who I think recently, in fact, I think Dr. Nishino saw that patient also. Very subtle weakness. The clue was one side was weaker than the other. Very mild scapular winging, very mild facial, lower facial weakness, and the genetics was positive. So again, we have to be humble. I think that's the key point, that we cannot be overconfident that we are completely right about one or the other. Just like when you are cooking, you must remember to use all 4 instruments, but use them selectively. But it could, by themselves, could be a problem. So muscle biopsy, as you know, in FSHD, myasthenia gravis, you can have what look like an inflammatory change. In a lot of muscular dystrophies like FSHD, it look like inflammatory change. I remember many times in the laboratory when I see a patient history, very severe proximal weakness since very young, and then I see the biopsy, nothing very specific, and then I call the doctor up and says, can you ask the patient to take off the shirt and look at the scapula? And then often there will be silence. Because why? The doctor has not actually exposed the patient to see the scapular winging. And then when you tell him to do it, you realize actually it was there. But the muscle biopsy was very non-specific. So again, if I didn't do the calling up and I report, or maybe there's some inflammatory changes here, there, then the doctor may think, oh, this is dermatomyositis or polymyositis, or myositis, inflammatory myositis, and treat the patient as myositis, right? So I think that's why I think Dr. Nishino is advocating that the pathologist has to work with the clinicians, or even better, the clinicians learn the pathology, clinicians learn the electrophysiology, and everything you do, if you do all the things yourself, or at least you have a team that works together, then you're less likely to go into mistakes. But your point is absolutely right. There are many, many pitfalls, just like driving in a road. There are many times there are a lot of potholes, you have to avoid the potholes.
I would actually raise the importance of muscle imaging in addition.
Oh yeah, I forgot about that. Yes, thanks.
Yeah, so for example, as he mentioned that of course muscle disease, most muscle disease show proximal muscle weakness. But in fact, if you look at muscle imaging data, not all muscles are equal. One muscle is almost completely gone, but other muscles are completely normal. This type of selective muscle involvement is very common in almost all hereditary muscle diseases. And also, yes, and neurogenic disease, the pattern is totally different. Actually, even for CIDP, they can show proximal muscle weakness. But if you do muscle imaging, I think you can somehow tell that is neuropathy or myopathic disease. So I think of course, I'm not very sure whether muscle MRI can be done very easily here, but I think it should be done, at least in the future. I think you should say that.
Agreed,
Yeah,
agreed.
Thank you. And I'm very impressed with the comment from the Professor Nishino because I learned from a lot from this both your lecture about what we can apply in Vietnam, especially like a very effective and multidisciplinary team like with the MRI in Singapore and also the MRI in Vietnam. We can apply that, and in fact, I think that we should do early, and because we can choose exactly where we should do the biopsy to get the better results. But it's come out also another question, one more question. It's it is a very complicated case like we concerned about this. In some case, we should think about the genetic to find out what exactly, and sometimes the family also they need to do something like this because we suspect about the muscular dystrophy, but the family ask we about how we could be sure about that. But the thing is, when we do the gene test, sometimes it's not always do get the right answer. So in that case, what you recommend about the how should we think about the
No,
gene test? Or, I mean that.
I've got the same worry. I'm always very scared about doing genetic tests because I'm worried about this, you know. So I try very hard to come to genetic tests after I've made some clinical diagnosis because I particularly because I'm weak in genetics, I find very difficult to sort out the variants. So I think there is a science to it. I think Dr. Nishino will probably be able to explain. But for my approach, I am always asking myself a hypothesis. In English, we have this term a priori hypothesis. That means you decide beforehand what is the most likely cause, and then you interrogate that particular. Then when genes come out, you know, okay, this is consistent with the clinical picture. But otherwise, therefore, I personally, when I do, but of course, a lot of times we get referred patients where they already done the genetic test, and then it becomes a nightmare. Then I have to call an expert like him. Yeah.
Well, of course, genetic testing like whole genome or whole exome sequencing is a powerful technique. I do agree. But it's often tricky. You shouldn't totally 100% rely on it. Maybe 30, 40, even 100 years later, it may be almost automatic with AI or something. But at this moment, as Umapathi mentioned, to interpret the data, you really need to be well trained. So it's not automatic. And when it comes to muscle disease, I always think that muscle disease, maybe I should say neuromuscular disease. Neuromuscular disease field is totally different from common disease, like diabetes and hypertension. For diabetes, hypertension, common disease, most important thing is how to make a diagnosis in the fastest way, in the most economical way, right? That's why they always establish guidelines. You should do this one only. You shouldn't do any more because you have so many huge number of patients. If you do comprehensive study for all patients, I think your country will be bankrupt, right? That's why you need to choose really the right one. But when it comes to neuromuscular diseases, all very, very rare, right? So as all professors always mention, we should learn from each patient, each one of patients, right? This is very important. There are still many things we don't understand, we don't know. So my policy is do everything for all patients. Of course, you shouldn't do unnecessary testing, but still, there are borderlines, gray zone. But if you're working in the hospital like this, university, this is actually the last defensive line in our country, right? It's not the small hospital in the jungle. So you should do everything you can do. This is the policy for muscle disease. Then we can learn one by one. Of course, you as well. But for this would be helpful for the next generation as well, right? This is how we learn, how we establish muscle disease field. That we still keep doing like this. Yes. So each one patient is very important. We should do everything we can. So they often ask me, whether we can skip something, we can skip something, we can skip something. Maybe you can make a diagnosis just by autoantibody testing or something, but I don't think this is the right way. At least, especially in this type of hospital, I think you should try to do everything. Right? That's my, maybe you may have different opinion.
I want to friendly remind that we have pediatric neurosurgeon around here. So this is the approach for adults. That's right, Professor?
Yes.
And any difference when we approach children, neurologic children?
I think it's the same. Of course, it's different how to examine patients. For example, I'm an adult neurologist. My background is adult neurologist, but for some reason I was asked to talk about how to approach patients in asthma speaking in that. But anyway, so I think the approach is different, of course. You can do manual muscle testing for implants, so you have to you have to observe how their actions. But still, I think the approach, diagnostic approach is basically the same. I think our basic policy is do everything. Of course, shouldn't do unnecessary testing, but basically we should do everything because the muscle diseases are so rare, right? Each patient is very important, and we can learn.
So I guess pediatrics, the only difference is that you think about genetic disease more than adults. But then on the other hand, this theory doesn't apply when you see an individual patient, right? So you still have to think about acquired diseases, inflammatory diseases, right? So general approach is the same.
We shouldn't be biased.
Correct.
Yeah,
Exactly. Individual disease, yeah.
Well, actually, we have infantile onset.
Correct.
myositis.
Yeah.
Like onset was 10 months old, something like that. So we shouldn't be biased.
So that's why it doesn't apply. Statistics don't apply when you see an individual patient, right? If an individual patient can have a number of diseases, so just because a young patient doesn't mean it's genetic, just because an old patient doesn't mean it's acquired, right? Yeah.
Dạ, em nghĩ chắc là cái phần thảo luận này chắc là có thể kết thúc được rồi. Thì như thầy Uma và thầy Nishino có nói, cái câu chuyện như là thầy Uma nói trong cái việc mà tiếp cận cái bệnh này, một bác sĩ lâm sàng mà học được cả điện cơ, học được cả giải phẫu bệnh, cả sinh thiết cơ đó là tuyệt vời. Nhưng mà cái điều này thì nó rất là khó, cho nên là cần phải có một cái team tốt. Chính là vì lý do đó mà cái workshop này là có các nhà giải phẫu bệnh và các bác sĩ thần kinh ngồi để làm việc với nhau. Giống như là bọn em mang hai thầy đến đây. Thì cái phần đầu tiên là
even though it's got a beaver.
Có nghĩa là các anh chị đã thấy được cái quan điểm của một bác sĩ thần kinh khi mà tiếp xúc một cái bệnh cơ như thế nào, và một cái bài của thầy Nishino thì cũng rất là hay. Thì bây giờ chắc là mình sẽ nghỉ giải lao 15 phút, sau đó chúng ta sẽ quay lại và chúng ta sẽ tới cái bài lý thuyết cuối cùng của sáng nay là bài của thầy Nishino, và thầy sẽ nói về cái cách đọc xin lỗi, cái gọi là thầy sẽ nói về chi tiết hơn về cái cách đọc cái sinh thiết cơ. Thì sau cái bài cuối cùng thì chúng ta sẽ nghỉ trưa, và buổi chiều nay thì chúng ta chỉ có thực hành thôi. Thì trong chiều nay thì chỗ thực hành thì chỗ anh Minh, kỹ thuật viên trưởng của bộ môn sẽ có cái hướng dẫn để chúng ta chia thành những cái nhóm, và buổi chiều nay thì là chỉ chuyên dành cho thực hành. Thì bây giờ thì chúng ta nghỉ giải lao trong vòng 15 phút và sau đó chúng ta quay lại với cái bài cuối cùng. We have a 15 minutes break.
Hi, good morning. I'm going to talk about muscle biopsy and fixation. This is kind of technical talk. Oops, I don't. So I always want to talk. I always want to start with this type of picture. So do you know the diagnosis? Anybody can tell? Where is Chuang? Yeah, you. So what is the diagnosis? Yeah, central cord disease. Maybe you are not familiar with muscle disease, but once you know the diagnosis, you understand why it is called central cord disease. You see something round in the center of muscle fibers. This is why this is called central core disease. Very easy, right? Even a small kid, I think if you tell them this is central core disease, I mean, tomorrow I think they can make a diagnosis very easy. But my real question to you is whether you can make a diagnosis of central core disease without muscle biopsy. I want you to think about it. What do you think? I don't know what do you think?
So I think central cause anxiety is we can diagnose in muscle biopsy.
Right.
But we found muscle biopsy which is connected vehicle.
Right.
And clinician sometimes neurology can give the information.
Right.
We have a team to make the diagnosis.
Very good. So, you know, actually this disease is known to be caused by RYR1 gene mutations. So some people may claim that, okay, if you can do gene testing without doing muscle biopsy. What do you think? Next lady, what do you think? You're a technician. You are a technician as well. Are you a doctor? Pathologist. What do you think? You have no idea. Okay. So actually, this is a little bit tricky question. Yeah, do you have an opinion?
Sorry, we need to briefly translate to visually.
Oh, okay. All right.
Thì đây là cái hình này rất là thường bắt đầu một cái bài báo cáo của mình. Đây là cái hình về bệnh central hay bệnh mỏi bệnh cơ ở trong. Đây là một cái nhóm bệnh congenital. Thì cái câu hỏi của thầy là chúng ta có thể chẩn đoán bệnh này bằng không có biopsy được hay không? Và các bác sĩ thì nghĩ cái gì về nếu mà làm xét nghiệm gen?
So it takes long time, double time. Okay, so if you need translation, I should move quickly. So this is central core disease, yes? And well, again, well, this can be, you may think that this may be diagnosed by genetic testing. Yes, but it's tricky because RYR1 mutations are not always associated with central core disease. Sometimes other disorders like malignant hyperthermia. Yes, so theoretically, because this disease is defined by pathological features, in theory, you need muscle biopsy to make a diagnosis of central core disease. So you can translate.
Cái bất thường gen RYR1 thì nó trước khi nó đôi khi cái bất thường gen này mà gây ra những cái bệnh lý khác ngoài central core, cho nên phân loại hiện tại vẫn là phụ thuộc vào bệnh.
Okay. In fact, many muscle diseases are at least partly defined by pathological features. For example, this is Nemaline. They are called Nemaline bodies. This is why this is called Nemaline myopathy. You see a lot of fibers with centrally placed nuclei. This is why this is called central nuclear myopathy. And this looks like myotubes. That's why this is called myotubular myopathy.
Tới hiện tại rất là nhiều bệnh lý được phân loại dựa trên bệnh học, bao gồm có bệnh Nemaline. Nó bởi vì chúng ta thấy là cái Nemaline body ở trong cái thiết cơ và macro phía bên trái, phía dưới thì có central core hoặc là bệnh cơ ở trung tâm.
So many muscle diseases are at least partly defined by pathological features. So to understand muscle disease, you need to understand muscle pathology.
Do đó thì để chẩn đoán được bệnh cơ thì chúng ta bắt buộc phải biết về bệnh học.
Okay, so then I will first talk about muscle biopsy.
Chúng ta nói tiếp về bệnh sinh cơ.
So muscle biopsy should be done to make a diagnosis of muscle disease, not to make a diagnosis of neurogenic disease or neuromuscular junction disorders, because muscle disease is defined by pathological features.
Và chúng ta sẽ thiết cơ để chẩn đoán bệnh cơ. Còn những trường hợp lại như là tổn thương thần kinh hoặc kỹ thuật thần kinh cơ thì chúng ta không có chịu thiết cơ.
Okay, but even among all muscle diseases, for some muscle diseases, you don't need muscle biopsy. For example, there are some conditions you don't really need to do. The most representative one is myotonic dystrophy and facial scapulohumeral muscular dystrophy. Myotonic dystrophy, if you look at the textbook, there are many interesting findings described, but none of them are really specific. While clinical features are very unique and specific, experienced physician can make a diagnosis, almost snapshot diagnosis, and EMG is almost diagnostic. So you really don't need muscle biopsy. FSHD is really, again, clinical examination is very important. And in FSHD, affected muscles are really severely affected, and sometimes you don't see any myofibers. But non-affected muscles are often almost normal. So if you do even if you do muscle biopsy, maybe you can see only normal muscle. So it's not really diagnostic. That's why you don't have to do muscle biopsy for myotonic dystrophy and
Tuy
FSHD.
nhiên là vẫn có những cái bệnh cơ mà chúng ta không cần ứng dụng sinh thiết cơ. Thứ nhất là myotonic dystrophy là những cơ tăng kinh lực. Thì cái sinh thiết thì được mô tả rất là nhiều đặc điểm khác nhau trên Facebook. Tuy nhiên là những đặc điểm này nó sẽ không đặc hiệu, mà triệu chứng lâm sàng và điện cơ thì lại rất đặc hiệu. Trường hợp thứ hai là bạn điện cơ mà ở vai cánh tay, đặc điểm lâm sàng rất là đặc hiệu. Tuy nhiên có những cái cơ bị ảnh hưởng và những cái cơ không bị ảnh hưởng. Nếu chúng ta sinh thiết trên cái cơ lành thì chính bản sinh thiết nó sẽ bình thường.
Yes, and of course there are increasing number of genetic hereditary disorders for which mutation screening is available. For example, Duchenne and Becker muscular dystrophy, and in Japan, Fukuyama congenital muscular dystrophy is the most frequent congenital muscular dystrophy. And all patients have the same mutation, so we screen for that. And that's very easy and diagnostic. For those disorders, mutation screening first, and if negative, we do muscle biopsy. And actually, the list is expanding. Yes.
Có những trường hợp xét nghiệm gen đã thay thế được sinh thiết cơ, ví dụ như là những cơ Duchenne, Becker, Fukuyama và bệnh cơ di truyền Fukuyama, hoặc là bệnh cơ GNI, đây là cái nhóm bệnh cơ ngọn chi, OPMD, hoặc là những cái bất thường về bệnh chi thể.
And in fact, now whole exome or whole genome sequencing are, available. So this list will be very long, and actually the situation will be totally different maybe in the next 10, 20 years. But still, muscle pathology is very important because many of the muscle diseases are defined by pathological features again. Yes.
Trong tương lai 10 hoặc 20 năm tới thì xét nghiệm gen hoặc cái xét nghiệm toàn bộ gen thì nó sẽ phổ biến, thì nó sẽ thay thế được sinh thiết cơ trong tương lai. Tuy nhiên hiện tại thì vẫn cần cái sinh thiết cơ để chẩn đoán và thu lợi.
Okay, then when we should do muscle biopsy? The first, age, there is no limitation. You can do muscle biopsy at any age. We have muscle biopsy specimens over 100 years. And we have muscle biopsies like 1 week, of age, something like that. So age, there's no limitation about age. But of course, for infants, when you need muscle biopsy, actually patients are very often very, very sick. So in that case, of course, management of the general condition is, of course, more important. Yes. But anyway, just in terms of muscle biopsy, you don't have to care about age.
Khi nào chúng ta là sinh thiết thì về độ tuổi thì bất cứ tuổi nào cũng có thể làm sinh thiết được, ngay cả ở trẻ thiếu nhi hoặc là trẻ.
And go ahead. Okay, and the disease stage is important. If you do muscle biopsy, really at the end, maybe patients don't have any myofibers, then we will not be able to diagnosis.
Ở giai đoạn muộn thì chúng ta cũng đánh là sinh thiết cơ, tại lúc đó chúng ta thấy là không còn bao nhiêu sợi cơ để mà chẩn đoán.
And we used to say that when you have a patient with, suspected to have myositis, we should do muscle biopsy as early as possible. Then, after biopsy, we should start steroid. This was what I learned when I was a student or when I was a resident. But now this should be changed because, there are many diseases. Yeah, for example, this one. This one is actually looks like muscular dystrophy. There is necrotic fiber, there are regenerating fibers, and a lot of fibrous tissue, fibrosis. So this looks like muscular dystrophy. But actually, this patient had myositis. One of myositis, it is called immune-mediated necrotizing myopathy, right? Because she was misdiagnosed as having muscular dystrophy. She was not, properly treated for 8 years. Then muscle becomes like this. Even if you start steroid with this condition, of course, efficacy is very much limited.
Chúng ta thường nghĩ là sinh thiết cơ nên làm sớm ở bệnh nhân bệnh viêm cơ tại vì chúng ta sẽ chữa sớm tránh hạn phế, còn những cái trường hợp còn lại có thể trì hoãn. Tuy nhiên cái quan điểm đó thì nó cũ rồi. Thế đây là một cái trường hợp mà một bệnh nhân nữ 16 tuổi được chẩn đoán là loạn dưỡng cơ, cái sinh thiết thì cũng giống như loạn dưỡng cơ, nhưng mà thực ra đây là một cái viêm cơ hoại tử có kháng thể HCM-city dương tính, thì mất một khoảng thời gian không có điều trị vì trì hoãn cái chẩn đoán.
So early diagnosis is necessary for all conditions, not just for myositis, because even if you think that your patient has muscular dystrophy, your patient may have treatable conditions. So you should do, if you think muscle biopsy is necessary, you should do it as soon as, of course, may not be today, but at least like next week, in 2 weeks, something like that, you should do it early. Okay. So this is another example. This slide was given by the former president of the Patient Society for Pompe disease. Maybe you can. Yes. So they had 2 daughters. Elder daughter had asthma from 1 year. Then at 4 years, she was found to have liver dysfunction and low height, and younger daughter has very similar clinical course, asthma, then liver dysfunction. Yes.
Đây là hai cái trường hợp, một cái bệnh nhi nữ thì có bị với cái đây là cái kiểu khởi phát của hai chị em, một cái người kiểu khởi phát là bắt đầu một cái bệnh gan, sau đó là triệu chứng của mắt.
So they were just followed up. But here, actually, with liver dysfunction, but most likely creatine kinase was elevated. And in this hospital, they suspected the possibility of muscular dystrophy, but they didn't do muscle biopsy.
Ở cái trường hợp mà khi mà người ta phát hiện ra có cái tăng men gan, người ta cũng nghĩ tới loạn dưỡng cơ, nhưng mà người ta không có làm sinh thiết cơ như thế này.
And later, this younger daughter developed cardiac dysfunction. Then finally, they suspected the possibility of Pompe disease, and the diagnosis was made, but it was too late, and she died.
Khi mà bệnh nhân tiến triển tới một cái bệnh tim thì bắt đầu người ta nghĩ tới Pompe disease, vậy người ta sinh thiết cơ để chẩn đoán, nhưng mà chẩn đoán lúc này là quá trễ rồi.
And of course, the elder daughter has the same condition, so they immediately also checked the elder daughter, and finally the diagnosis of Pompe disease was made. So this was after, 8 years after the onset. The diagnosis was very much delayed, and of course, she is still on wheelchair bound, and she's very sick. Yes, she's survived, but the condition is, not so good.
Cái trường hợp người chị thì được chẩn đoán sau đó nhưng mà mất cái thời gian là 8 năm và do đó là bệnh nhân tàn phế hoặc là.
So something I'm really sad about is this one. So if they did muscle biopsy, I'm 100% sure diagnosis was made here, and both sisters survived, and the condition should have been much, much better.
Đây là một trường hợp đáng tiếc nếu mà chúng ta sinh thiết cơ sớm, nếu có trường hợp người em đó thì có thể là cả hai cùng được chẩn đoán sớm và đã sống sót.
Yes. So muscle biopsy should not be delayed. If you think it's necessary, you should do it now, not next year or something like that. You should do it now, okay? Because treatable disease is increasing, and all the treatable conditions, the earlier you start treatment, the better the outcome is.
Cho nên là chị sinh thiết cơ thì không nên trì hoãn, thì nó tăng nhiều hơn và chữa càng sớm thì cái outcome nó càng tốt.
Okay, then which muscle should we biopsy? The selection of the biopsy site is very important. First, degree of involvement, mild to moderate. If you do muscle biopsy from really normal muscle, what you get maybe just normal muscle. But if you do muscle biopsy from really weak muscle, what you get maybe just fat, so you cannot make a diagnosis. So you should choose mildly to moderately elevated muscle, the weak
Chúng
muscle.
ta nên sinh thiết cơ nào thì thường là chúng ta sẽ chọn những cơ yếu mức độ nhẹ tới vừa, không nên chọn cái cơ quá khỏe thì chúng ta kết quả sẽ bình thường. Cơ quá yếu thì chúng ta sẽ không còn nhiều sự cơ để chẩn đoán và lựa chọn có thể là dựa trên hình ảnh học.
Yeah, and now in Japan at least, we, tell all the physicians to do muscle CT or MRI before muscle biopsy because, for example, this is the muscle CT from limb-girdle muscular dystrophy. In limb-girdle muscular dystrophy, we learned that proximal muscles are affected. Yes, this thigh muscle is affected, but you have to be careful. Not all thigh muscles are equally affected, right? Some muscles are very much severely affected, while some muscles look almost normal. So you have to carefully choose the right muscle after doing imaging analysis.
Ở Nhật Bản thì hiện tại hầu như là 100% bệnh nhân thì được chụp MRI hoặc CT scan trước khi một cái cơ. Tại vì chúng ta biết là đối với trường hợp là những cơ một góc chi thì cái cơ bị ảnh hưởng nó tách chi nó không có đồng đều, có thể cơ này bị ảnh hưởng rất nặng nhưng mà cái cơ kia thì lại hoàn toàn bình thường. Cho nên chúng ta sẽ lựa chọn dựa theo cái mức độ tổn thương trên thể học.
And for myositis, you must do MRI instead of CT because you need to identify edematous lesion.
Với viêm cơ thì chúng ta dựa vào MRI chứ không phải là CT scan để chúng ta muốn thấy là cái hiện tượng phù cơ trên MRI.
Another consideration is if you look at if you read textbook, it says that normally there are three fiber types, type 1, 2A, and 2B, three fiber types. They are almost like one-third composition and distributed in a mosaic or checkerboard pattern. That's what he says. But it's not always true, depending on the muscle. So certain muscle, for example, paraspinal muscles, have a lot of type 1 muscle, type 1 fibers, because type 1 fiber is red muscle or anti-gravity muscle. So like paraspinal muscles have a lot of type 1 fibers from the beginning. But type 1 fiber predominance, it means that you have a lot of type 1 fibers. This is one of the very important diagnostic feature of congenital myopathy. So if you do muscle biopsy for paraspinal muscle and if you find type 1 fiber predominance, you can tell whether this is from the beginning or from the disease, right? That's why you should do muscle biopsy from the muscle in which you are sure that the composition is one-third, yes.
Trên sách vở chúng ta có nhiều cái sợi cơ tiếp một, tiếp hai, thứ ba nó trộn lẫn vào trong một cái cơ. Tuy nhiên là không phải bất kỳ cơ nào đều có cái mức độ tiếp một, tiếp hai nó giống nhau. Ví dụ những cơ cạnh sống thì những cái cơ này là những cơ giữ trọng lực, cho nên là cái thành phần tiếp một nó sẽ nhiều hơn. Và bất thường cái tỷ lệ của tiếp một, tiếp hai đó có thể là ảnh hưởng đến cái chẩn đoán, cho nên là cái việc chúng ta lựa chọn cơ chúng ta phải biết chúng ta đang lựa chọn cái cơ nào.
And also, if you can, you should avoid gastrocnemius muscle biopsy because gastrocnemius is always under mechanical stress. So it's often very difficult to differentiate chronic neuropathic and chronic myopathic condition. Very difficult. So, of course, if you have like an inflammatory lesion, of course, only in gastrocnemius, of course, you have to choose gastrocnemius. But if you have several options, you should avoid gastrocnemius.
Thường là chúng ta sẽ tránh chọn cơ ở trên trong để mà thực hiện sinh thiết cơ, tại vì cơ này nó bị ảnh hưởng bởi tác động từ lực hoặc là những cái bệnh lý về thần kinh, ví dụ bệnh suy tạng chẳng hạn. Cho nên là nếu mà chúng ta có nhiều lựa chọn khác nhau thì chúng ta sẽ tránh lựa chọn cơ này.
Okay, so again, pattern of muscle involvement is very different depending on the muscle disease. And now, well, just by analyzing the pattern of muscle involvement or muscle imaging, maybe you can make a diagnosis. Even at least narrow down the diagnosis. So the importance of muscle imaging is getting more and more recognized nowadays.
Với hình ảnh học mà chúng ta đánh giá được những cái cơ nào bị ảnh hưởng thì chúng ta có thể thu hẹp được cái chẩn đoán phân biệt.
Okay, and again, for inflammatory disease like myositis, you need MRI, and you can detect this type of myoedema.
Ở đây là cái hình MRI của skin thì chúng ta thấy hiện tượng thì cơ trên cái mặt cái ngang.
Yeah, for example, this case, this is one kind of myositis. You see, edema is only in the backside muscle. If you just routinely do muscle biopsy from quadriceps muscle, you don't get anything, right? So you have to choose the right muscle after muscle in our MRI.
Cái hình phía bên phải trên này là một cái viên cơ hoại tử qua trung gian nhiễm dịch thì chúng ta thấy rằng hai cái hình của cơ đùi thì cái cơ phía mặt sau cơ hamstring bị ảnh hưởng nhiều hơn. Nếu mà thông thường chúng ta sẽ biết cơ phía đầu đùi thì có thể chúng ta sẽ biết cái chẩn đoán.
And also sometimes the electrophysiologist said that you do EMG from one side, and if you find abnormality, you do muscle biopsy from the other side. This often works, but sometimes doesn't work. Because, for example, look at this muscle. This is gracilis muscle. This one is edematous, but not this one, right? So it's not always symmetric. So EMG, of course, often helps, but for the selection of the biopsy site, MRI is much more powerful.
Các nhà điện sinh lý thì thường là thực hiện cái cơ ở một chi và sinh thiết cái cơ chi còn lại. Nó thường là đúng nhưng mà không phải lúc nào cũng đúng. Như trường hợp này chúng ta thấy là cơ may một bên bị ảnh hưởng, một bên không bị ảnh hưởng.
Okay, when we do muscle pathology analysis, I always ask the physicians to send us muscle imaging data as well nowadays.
Khi mà làm sinh thiết cơ thì chúng tôi thường là bác sĩ lâm sàng và gửi chúng tôi cái hình ảnh học.
Okay, so for anesthesia, well, in our hospital, for all pediatric patients, we use general anesthesia as well. But for adult patients, usually only local.
Đối với trường gây mê thì ở bệnh nhi thì chúng tôi thường là gây mê toàn thân. Ở người lớn thì có thể gây mê tại chỗ.
And this is very important. Local anesthetics will necrotize myofibers. So it should not be injected to the muscle. You can use it only in subcutaneous tissue.
Cái việc gây tê thì chúng ta sử dụng những việc gây tê và chỉ dưới da mà thôi, hoàn toàn không được tiêm bất kỳ chất lỏng nào vào trong cơ.
So it means it is painful. So you have to tell the patients beforehand.
Do đó là sinh thiết cơ nó cũng đau, chúng ta phải thông báo trước với người.
Okay, so this is the procedure. First anesthesia, then you will open the skin, then you will separate subcutaneous tissue, then you see fascia. Then you will make an incision onto the fascia, and you will take that muscle and you will close it.
Đây là cái quy trình sinh thiết cơ thì các bạn có thể thấy là chúng ta gây tê hoặc gây mê, sau đó là rạch da, bóc cái mô dưới da, những cái mô mở dưới da, sau đó là cắt cái bao cơ, lấy mẫu cơ và khâu bao cơ và khâu da.
So local anesthetics, again, it should be used only to subcutaneous tissue, and the size is very important. Many physicians think that, okay, I think they want to be least invasive. So they try to, take a really small amount of, small piece of muscle. Many physicians believe that this is better for the patient, but it's not actually. The diagnostic finding is not uniformly distributed, often like a patchy pattern. So if you take a small piece, the probability that you reach the diagnosis will be decreasing. If you, get a big muscle, of course, the diagnosis, the probability will be increasing, right? But I don't think you can take the whole muscle. So you have to, limit the size. So I think the best size is pencil size, for adult at least. Of course, if you do muscle biopsy from the infant, you should make it smaller, but pencil size. The pencil is, I think, the same, you have the same size pencil everywhere, right? Okay.
Nhắc lại là cái tên thì chúng ta chỉ cái tên mô lý da mà thôi, và về cái kích thước của mẫu cơ chúng ta lấy thì nó rất là quan trọng, bởi vì một số bác sĩ thì lấy mẫu nhỏ thôi để tránh nó gây cái tổn thương lớn cho người bệnh, thì họ nghĩ rằng chuyện này tốt cho người bệnh, nhưng mà thực sự là không phải như vậy, bởi vì nó ảnh hưởng đến chẩn đoán. Chúng ta biết là cái bất thường ở trên một cái diện cắt ngang thì nó thể là phát chi, có thể chỗ này có, chỗ kia có, chỗ nọ người không có. Do đó chúng ta nếu mà lấy mẫu nhỏ quá, chúng ta sẽ bỏ sót chẩn đoán. Cái kích thước mà tốt nhất là bằng một cái cây viết chì.
And you shouldn't tie up the sample. It's not a vessel, so you can just, cut it. And also don't use electrocautery. You can use it after taking out the sample, but before taking out the sample, you shouldn't use electrocautery.
Đặc biệt là chúng ta sẽ không cột mẫu cơ lại và không sử dụng đốt điện trong lúc mà làm thủ thuật. Nếu mà lấy mẫu ra rồi chúng ta muốn cầm máu và đốt điện thì ok, nhưng mà trong lúc làm trước khi chúng ta lấy mẫu thì chúng ta sẽ không đốt điện.
And this is very important. After taking the sample should not be dried. So it has to be wrapped with wet gauze. But the level of wetness, this is very important. It should be very, very wet. If it is very wet, the sample will get artifacts, right? So it should be well squeezed. Okay, this is very important.
Lưu trữ mẫu rất là quan trọng. Chúng ta phải bọc nó trong một cái gạt ẩm. Lưu ý là gạt ẩm và không được quá ướt. Nếu mà quá ướt thì cái mẫu cơ nó sẽ bị artifact. Và nếu mà chúng ta để quá khô thì mẫu cơ nó sẽ bị bảo quản không tốt.
Okay, so we have video. I guess I have limited time, so you can just access the video and you can watch it later. I have video here, but I will skip this. This was actually made with, in collaboration with Syria Hospital in Thailand, but you can just watch it. So then, after taking the muscle, now you have to fix it. For muscle disease, freeze fixation is the most important. And in many pathology laboratories, they want to do formalin fixation, but I don't recommend to do it that much. And if you really want to do it for your like a historical reason or traditional reason or whatever, you can use formalin fix the sample only a small piece, but the main part should be frozen.
Với cái phương pháp cố định thì chúng ta có thể cố định freeze một định tâm lạnh hoặc là formalin. Tuy nhiên là ông hầu như là rất ít khi đề nghị là làm formalin, mà thường là phải cố định phương pháp đông lạnh.
And glutaraldehyde fixation is for electron microscopic observation.
Glutaraldehyde cố định bằng glutaraldehyde thì thường là sử dụng cho tính vi điện tử.
And the way in our hospital, we also take a piece of muscle for myocyte culture. Muscle culture, and the cells. Yeah, well, you don't have to, but in our hospital we do it. Cell culture. Okay. Well, okay. So this is the muscle, our muscle sample. So the pencil size is like 8 millimeter diameter. So you need to make it stand onto the piece of cork using gum track counts like this.
Đây là kích cỡ của cái mẫu cơ tinh khiết từ cái đường kính bằng một cái đầu chỉ.
Okay, there are two methods to fix the muscle for freeze fixation. One is using liquid nitrogen and isopentan. The other one is acetone and dry ice.
Có hai cách để chúng ta cố định lạnh. Thứ nhất là sử dụng isopentan với nitơ lỏng. Cách thứ hai là acetone và acetone.
Basically, for muscle, you want to fix the muscle at the temperature as low as possible. That is the basic concept, okay?
Cái nguyên lý là chúng ta muốn cố định mẫu cơ bằng cái nhiệt độ thấp nhất có thể.
So the lowest temperature available is liquid nitrogen. Okay?
Và cái nhiệt độ thấp nhất mà chúng ta có là nitơ lỏng.
So the liquid nitrogen is minus 196, okay, degrees.
Nhiệt độ của nitơ lỏng là âm 196 độ C.
Because liquid nitrogen is very, very cold, why don't you put it the sample directly into the liquid nitrogen, right? Because you want lowest temperature. That is the lowest temperature. Why don't you do it?
Nhiệt độ với nitơ lỏng thì rất là lạnh rồi, nhưng mà tại sao chúng ta không bỏ cái mẫu cơ vào nitơ lỏng?
This is because liquid nitrogen, if it is warmed even a little bit, it will be immediately changed to gas, nitrogen gas.
Bởi vì cái nhiệt độ nitơ rất là dễ chuyển đổi thành cái dạng khí.
So if you put the sample into the liquid nitrogen, this will be immediately surrounded by gas.
Do đó khi chúng ta bỏ mẫu cơ vô thì cái môi trường xung quanh lập tức chuyển đổi thành môi trường khí.
The efficiency of the heat, warming or cooling the efficiency of the gas is very low, while the liquid is high. So you can feel that, if, for example, the refrigerator is 4 degrees, okay? If you put your head into the refrigerator, you just feel cool and feel very nice, right? Especially in your country, right? But if you go into the 4-degree water, you will feel so cold, right? So the same 4 degree, but totally different, because liquid, the cooling efficiency is much, much higher in liquid.
Chúng ta sẽ gặp một cái vấn đề về khả năng truyền nhiệt của khí thì nó sẽ rất là kém. Một cái ví dụ là chúng ta đưa cái đầu chúng ta vào trong tủ lạnh cùng với nhiệt độ 4 độ C trong tủ lạnh thì chúng ta thấy là ok mát thôi. Nhưng mà cùng 4 độ C đó nếu chúng ta nhúng vào nước thì chuyện hoàn toàn khác biệt. Tại vì cái khả năng truyền nhiệt của nước nó sẽ rất là tốt.
So the surrounded by gas, this is not good at all to fix the muscle.
Do đó mẫu cơ bị bao quanh bởi không khí thì sẽ không tốt cho cái chuyện fixation.
So you have to find some liquid which cannot be easily turned to gas.
Do đó chúng ta cần một cái dung dịch nào đó mà truyền nhiệt được nhưng mà không bị bốc hơi.
And that is isopentane.
Và đó là isopentane.
So you put the isopentane into the beaker, and you put the beaker into liquid nitrogen, and you will cool isopentane as low as possible.
Chúng ta bỏ isopentane vào cái cốc thủy tinh và nhúng cốc thủy tinh lại vào nitơ lỏng để cho isopentane đạt nhiệt độ thấp nhất có thể.
That is the coolest temperature at the liquid status is called freezing point. The temperature is freezing point. This is 0 degree for water, right? After 0 degree, it will be ice, not water anymore, right? So this is the case for isopentane as well. At freezing point is minus 160 degrees. After this, lower than this, it will be a solid, not the liquid anymore.
Cái nhiệt độ thấp nhất mà cái dung dịch có thể đạt được đó là khi mà nó chuyển thành thể rắn. Và đối với nước là 0 độ C, nhưng mà đối với isopentane là 160 độ C thì ở cái mức này thì ở đấy chúng ta thấy có những cái tinh thể rắn.
So actually the muscle sample should be frozen at minus 160 degrees, okay?
Cơ thì sẽ được cố định ở cái nhiệt độ âm 160 độ C.
Yeah. And for acetone and dry ice, I don't go into the detail, but the dry ice is minus 679 degrees. And so with this method, you will fix the muscle at minus 79 degrees.
Với đá khô thì nhiệt độ của nó là âm 79 độ C.
You may think that both are very cold. Yes, but the difference is 81 degrees. 81 degrees higher than your temperature, your body temperature, is 120 something, right? It's very, very hot. You will have a lot of problems. So it means that difference is very big.
Âm 79 độ C thì cũng là lạnh rồi, nhưng mà cái cách biệt đó là so với cái phương pháp đầu là âm 81 độ C, cho nên là cái kết quả cũng sẽ rất là khác biệt.
And of course, this is much, much better. So you, at the university hospital, I think you should do this method. You should use this method.
Cho đó phương pháp đầu tiên thì nó rất là tốt hơn rồi. Ở cái viện trường thì chúng ta nên sử dụng pháp này.
So again, I have video, but I will skip it because it takes time.
Đây là một cái video về cái cách lấy mẫu sinh thiết nhưng mà chúng ta không có thời gian cho nên là skip rồi.
Yeah, and the muscle should be kept in the deep freezer minus 80 degrees. And when you keep it, you have to put it into the airtight vial because otherwise will be freeze dried. And when transport, when you carry the muscle somewhere, you should always do it with dryers.
Sau khi mà cố định thì chúng ta phải giữ cái cơ này ở cái nhiệt độ rất là lạnh sâu là âm 80 độ C. Thì thường là chúng ta sẽ bỏ vào trong một cái bình kín, hoặc là trong cái quá trình vận chuyển thì chúng ta cũng phải đảm bảo là nó âm 80 độ bằng cái đá khô.
Yeah, in our center we have this type of freezers, a lot of freezers, and keep them. Yes.
Đây là cái tủ lạnh âm sâu ở trung tâm của chúng tôi.
Okay, anyway, once it is frozen, you should never ever defrost it.
Khi mà đã đóng băng cái mẫu cơ này thì không bao giờ chúng ta làm tan nó.
Yeah, and you will make a section with cryostat. Yeah, so that's all. I think this is all. I already used 1 hour, so I will stop here. So if you have any questions, so I have 1 hour, right, for this one? Yes. Yes, okay, so that I will stop here.
Các bạn có câu hỏi gì để đặt cho về mặt kỹ thuật, về mặt lựa chọn bệnh?
Dạ, các anh chị có câu hỏi gì không ạ? Câu bài thứ nhất là của thầy Nishino, thì em nghĩ đây là một cái cảnh của các bác sĩ giải phẫu bệnh và các kỹ thuật giải phẫu bệnh. Cái bài này chị có câu hỏi gì không?
So if you have any question, I'm happy to take.
Ở mấy cái trung tâm ở Việt Nam là có nơi nào có đi tơ lẫn mà ở miền Bắc, miền Trung có đi tơ lẫn không?
And we do international muscle school. With this, we practice fixation and whatever. So we do this in Bangkok, in Srila Hospital, every year, but it was postponed because of COVID-19. But this year, in November, we are scheduled to have it, the 3rd International Muscle School. So if you are interested, please check the website and you can find it. You can find the information.
Good morning, Professor. I would like to add a small question. If by accident, when I process of EMG, after how long I can muscle biopsy
Right.
or the result?
Right. So once muscle, if you do EMG, theoretically, you may necrotize the muscle fiber. Once myofiber is necrotized, it usually takes 1 month to 1.5 months to be completely regenerated. So theoretically, you have to wait like at least 1 month, yes. But I don't think you can wait for 1 month. So I think you may need to do it even if you know that you did muscle, EMG. So you should tell the pathologist that you did EMG from this muscle when, like two weeks ago, one week ago, or yesterday. This type of information would be very important.
Câu hỏi của anh rất là hay là chúng ta làm những cơ còn cái cơ chúng ta sẽ sinh thiết rồi đó thì dự định là sẽ sinh thiết thì bao lâu chúng ta sẽ có thể thực hiện sinh thiết, thì thầy nói là về mặt sinh lý thì nó có khoảng 1,5 tháng để cái cơ nó phục hồi, do đó nhưng mà chúng ta cũng không thể để 1,5 tháng để mà dụng ráng, do đó là vẫn sinh thiết được, nhưng mà chúng ta sẽ báo như thú bệnh là cái cơ này tôi đã làm bị cơ trên nó đây khoảng bao lâu.
I asked Dr. C not to translate because it takes time. But my lecture is very simple. I show just picture and this is this is this. Very easy to understand, okay? So we do a lot of histochemical stains like this. Of course, you don't have to, remember everything, but we do this type of a lot of histochemical stains for all cases in our laboratory because we are the last defensive line in our country. So our policy is we do everything we can do. So among them, H&E, hematoxin and eosin, modified gomery trichrome, the green one, and NADHDR. They are the most important to understand muscle disease. So my mentor, Dr. Nonaka, always mentioned that if you understand those three stains, you can make a diagnosis of at least 90% of muscle diseases. So understanding those three are very important. So I will talk about those stains mainly. And the remaining one, ATP, blah, 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 they are myosin ATPase. Because you have to use different pH conditions before actually performing ATPase. There are different pH numbers. But anyway, this is to differentiate fiber types. Okay? So this is for fiber type analysis. So I will talk about this one as ATP. Okay? If you have any problem, you can just tell me. I will talk again. So basically, after all reading muscle pathology, we want to separate neuropathic and myopathic condition. But actually, again, muscle pathology is performed to make a diagnosis of muscle disease, not neuropathic disease. So basically, all of the changes are muscle disease, myopathic changes, except for group atrophy and fiber type group. They are the only neuropathic findings, okay? All right, so hematoxin and eosin. So this is the most important stain. I think this is also the case in other fields of pathology as well. So H&E is, in a sense, everything. And all other stains are just additional or supportive, studies, not the main one. So H&E is everything. So you have to describe all the changes, basically. So as I will show you in the next slide, muscle fibers are clustered in groups called fascicles. So you initially observe fascicles, structure of fascicles first. Then you observe each muscle fiber size, shape, and for example, you sometimes see necrotic fiber, regenerating fiber, and sometimes muscle fibers have vacuoles. So if you see any abnormality, you should describe everything on H&E. And sometimes nucleus is abnormal. And now you go into interstitium. Of course, if you see inflammatory cell infiltration, of course you describe it. And if you see fibrosis, of course you will describe it, everything. And there are other changes as well, like vessel abnormality or whatever. You describe everything here, H&E. Okay. So this is normal muscle. So as I mentioned, muscle fibers make group, cluster. This is called fascicle, okay? So there are two types of interstitium, okay? One is the space between the fascicles. This is called perimygium. Another one is the space between myofibers within the fascicle. This is called endomygium. Okay, there are those three terms: fascicles, perimygium, endomygium. Those three technical terms are the most important technical terms to understand muscle pathology. So please do remember those three terms. This is very important, okay? Those three. You can forget everything else, but you should remember those three terms because these three terms are the most important to understand muscle pathology, okay? Fascicle, perimygium, endomygium, okay? I'll go to the next. Okay, so, but actually, there are other structures as well. What is this? Many people think about vessel, right? But if this is a vessel, this is strange, right? Within the vessel, you should see only blood cells, red blood cells, leukocytes. They don't look like blood cells as well, at all. They are actually specialized myofibers, and this is peripheral. This is actually muscle spindle, right? Muscle spindle is a sensory organ which detects how much muscle is stretched, right? So by this special muscle. This is called intrafusal fibers. They sense how much muscle fiber is actually stretched. Then this signal is transmitted to all the way to spinal cord and eventually to the brain. Another one, and this is peripheral nerve, intramuscular nerve. And if you look at this very carefully, actually this goes in between the myofibers, and this is neuromuscular junction, and this is one as well, this goes in, and this is neuromuscular junction. So it means that they are motor nerves, right? You sometimes do sural nerve biopsy, but they are all sensory nerves. You never have a chance to do motor nerve biopsy because it will cause paralysis. But if you do muscle biopsy, you sometimes have motor nerve. So this is a precious opportunity to evaluate motor nerve. Why don't you observe it, evaluate it, right? So we always evaluate, intermuscular nerve as well. Okay, so this is the magnified version of normal muscle. Again, yes, usually the fiber size diameter is 50 to 80. Maybe, maybe women up to maybe 70. But anyway, so within this range. And if the diameter is more than 100, we call it hypertrophic fiber, okay? And again, this one, endomysium. You remember? The space between myofibers is called endomysium. Look at this endomysium. What can you see? What can you see in this endomysium? Only white line, right? This is very important. Nothing. Okay? In the endomysium, there is nothing. Okay? Of course, if nerve comes in, of course, you have some amount of fibrous tissue or something. But where there's no nerve, no vessel, there's nothing in the endomysium. This is very important concept. Okay? Normally, you don't see anything in endomysium. Please remember this. And myonuclei are located at the periphery of muscle fiber because muscle fiber is the organ to stretch, right? Nucleus cannot be stretched, right? So something cannot be stretched is present in the center of muscle fiber. It's very difficult to stretch, right? That's why they are pushed away. Okay, so normally they are present at the periphery. Okay, look at this one. It's exactly the same as this one. So it means that there is the fibrous tissue between the myofibers, so in endomysium, where you are supposed to see nothing, right? So you can immediately say that there is fibrosis. But, when I see young resident presenting a case at some conference, when they talk about fibrosis, they always point out here, okay, there was fibrosis. But, maybe fibrous tissue is increased 5%. But you cannot tell whether this is from the beginning or increased by fibrosis. It's impossible, right? But here, normally there's no fibrous tissue. But now you see fibrous tissue. You are 100% sure there is fibrosis, right? So when you discuss fibrosis, you should look at endomysium, not perimysium, okay? So when we write a paper, actually, we always specifically use the term endomysial fibrosis. Endomysial fibrosis was mild, not present, whatever. So we always use the term endomysial fibrosis. Then the reviewer understands, okay, this guy knows muscle pathology, right? If you just say interstitial fibrosis, we're not so sure whether you know muscle pathology or not, right? Because interstitial fibrosis, of course, it's not the wrong term, but not very specific. I'm not sure how you judge it, But if you use the term endomysial fibrosis, now everybody can understand. You specifically look at endomysium to evaluate fibrosis, right? So this is a secret signal, right, to communicate with review or other people. Okay, so this is very important. That's why I said endomysium, perimysium, fascicle. This is very important. Okay, let's move on to fascicle. Can you recognize the fascicle? No. Of course, they are all fascicles, but original shape of the fascicles cannot be recognized. Of course, this is because of fat infiltration. So in the advanced stage, fascicles, original shape of the fascicles cannot be recognized. By saying so, you can somehow tell how much fat infiltration is seen in the muscle. And how do you describe this abnormality? Of course, probably even the small kids said, there are small ones here, big ones there, something like this. I think the small kids will say something like this. They are correct, exactly right. But if you use the technical term, just learned, fascicle, you may say it like this. In the lower fascicles, all fibers are atrophic. In the upper fascicle, most fibers are hypertrophic. Now it sounds like you sound like expert, right? Just by using the term fascicle. But actually, what you are saying is the same as the small kid. But just by using the term fascicle, you sound like an expert. So technical terms should be used like this. By the way, this is a large group atrophy. All fascicles, all fibers in the fascicle is atrophic, right? This is called large group atrophy. This is actually an example, the case from Welnick-Hoffmann disease, or SMA1, spinal muscular dystrophy, atrophy type 1. This is, of course, this is a neurogenic condition, and nowadays you are not supposed to do muscle biopsy, but this is the case from like 30 years ago. But if you do muscle biopsy, you see this type of large group atrophy. And look at the atrophic fibers. All fibers are round in shape. So people believe that if you see round-shaped grouped atrophic fibers, this is most likely congenital neuropathic condition. In contrast, this is also large group atrophy. It may not look like the whole fascicle, but almost whole fascicle, right? Atrophic. Of course, there are some round shape, but most of them are a little bit elongated and angular. These type of angular atrophic fibers are seen in acquired neurogenic condition. And this is a case with ALS. Of course, to make a diagnosis of ALS, you are not supposed to do muscle biopsy. But if you do muscle biopsy, you will see something like this. How about this abnormality? Where are atrophic fibers? So you see atrophic fibers here. They are present at the periphery of the fascicles, right? So this is why this is called perifascicular atrophy. And this is very important finding to make a diagnosis of dermatomyositis. And there are many, names, to indicate specific finding of muscle pathology, but many of them are not so specific. Very specific and very diagnostic. There are only few of them, and this is one of the rare, examples. So you should remember this one. This is the very most important one, right? So then you will look at myofiber. Once myofiber is necrotized, usually by protease, everything is liquefied like this. So I think in normal myofiber, you can see some pattern inside the myofiber. But within this necrotic fiber, you don't see pattern, just liquefied, pale pink. Then once necrotic, now macrophage will come in to, clean up all the destroyed and liquefied cytoplasm. And at the same time, some of the myonuclei, they are actually stem cells called satellite cells. They start dividing themselves and making early regenerating fibers. So this is the early regenerating fibers. You see if you read the textbook, they say that early regenerating fibers have basophilic cytoplasm and enlarged nuclei with big nucleolus. Yes, they are right. But if you just read like this, text like this, you will feel sleepy, right? But I think we should understand what it means. Yeah, if you look at the electron micrography, actually this is early regenerating fibers. How can you be sure that this is early regenerating fibers? This is the myofiber membrane. And this is the next fiber, and also this is the next fiber. You can see beautiful myofibrils, right? The Z line, right? This one as well. But this one, you see only, half-formed myofibrils. So you can tell this is the early regenerative fiber. The myofibrils are only a little bit of myofibrils are produced, okay, synthesized. And you see a lot of dots within these myofibers, within the nucleus and within the cytoplasm. They are all ribosomes, okay? Ribosomes are composed of ribosomal RNA and ribosomal proteins, okay? And all ribosomal proteins are basic in nature. Basic means alkaline. So you have something alkaline within this myofiber. That's why this is stained basophilic in color. And you have big myonucleus. What is myonucleus? When DNA is, when gene is expressed, your DNA has to be released. In chromosome, DNA is in compact form like this. But this, you cannot express DNA, gene. You have to loosen this one. So you lose this part, and now you can express, the gene. Actually, the place where DNA is loosened and gene is expressed is my nucleolus. What is ribosome? Ribosome is a machinery for translation, right? And nucleolus means this nucleus is making, producing expressing a lot of genes. So this means transcription, right? So they are doing a lot of transcription and a lot of translation. So this means that what we are saying that, okay, basophilic cytoplasm, big myonucleus, means a lot of translation and a lot of transcription. And this is, of course, because they have to make their body. So they are making, synthesizing protein at their maximum speed. This is what we are seeing, on muscle pathology. Okay, so this, I'd like to discuss the mechanism of myofiber necrosis. In Duchenne muscular dystrophy, for example, myofiber membrane is fragile because you don't have dystrophin, okay? And because myofiber is always under mechanical stress. So at one point, you have more mechanical stress in one place, then you will have a hole, small hole. If you have a small hole, large amount of highly concentrated calcium will come in because the calcium in extracellular space is very high. The concentration is very high. But this is going to be a big problem for muscle because myofiber is made to show contraction with small amount of calcium. I don't go into the detail, but every time when you receive signal from the motor neuron, small amount of calcium is, released, then muscle fiber is show contraction. But with this mechanism, you have large amount of highly concentrated calcium will come in. Then what's going to happen is you have hypercontraction. This destroys everything. This is actually believed to be the mechanism of necrosis. And once destroyed, and the protease, called calpain, will liquefy everything, then macrophage will come in, and the cells, started divide themselves, and eventually they fuse with each other, and this is early regenerating fibers, and within 1.5 months will be normalized. Okay, so I will show this one with a picture. This is normal one, and this is a typical necrotic fiber. This necrotic fiber, this type of picture can be seen within 24 hours. Okay, so if you see this one, you can tell that necrosis occurred within 24 hours. But in others, so this is really early regenerating fiber, then gradually matured. So let's say this is maybe a few days, 3-4 days, and this is maybe 5 days, 1 week, maybe 2 weeks. Then yes, eventually, after 1 and 5 months, this will become normal-looking fiber. So necrosis, of course, this immediate necrosis. But if you see regeneration, you can tell that there was past necrotic event, right, within 1.5 months. Okay, let's look at this muscle. This is a muscle from Duchenne muscular dystrophy. Look at this one. There were necrotic fibers, right? And there are regenerating fibers. Okay? So it means that in this muscle, necrotic events occurred at least 2 times, not just 1 time, right? So this was maybe within 24 hours. Maybe this is maybe 3 or 4 days ago. Actually, if you look at it more carefully, there are other necrotic regenerative fibers. For example, this one, you still have nucleus in the center, but looks more like normal-looking fiber. So it means probably this is already like 3 weeks, 4 weeks. So it means that in this muscle, necrotic events, not just 1 time, occurred again and again. In addition to that, you see endomygeal fibrosis. This is not white, right? Something pale pink. It means that there is fibrosis. Fibrosis does not occur within a few days. It takes time. So it means that this is a chronic disease, right? With necrotic events again and again and again. This is muscular dystrophy, right? This really the feature of nature of muscular dystrophy. So just by one H&E picture, you can tell, you can feel all the features of muscular dystrophy, just by one picture, right? So this is something we need to know from the muscle pathology. Another form of necrosis is microinfarction. You see huge area of all myofibers were necrotized like this, and NADH, no enzymatic activity like this. And interestingly, with this type of necrosis, macrophage doesn't come for some reason. I don't know. Nobody knows the reason. Yes. This is called microinfarction. And this microinfarction is typically seen in some type of dermatomyositis, especially in kids. Okay, and when myofiber becomes hypertrophic, probably they will have nutritional problems. So that's why they will become, fibers become splitted. So this is called fiber splitting, like this. But usually, fiber splitting reflects fiber hypertrophy, myofiber hypertrophy. What do you think about this one? What's the abnormality? Yes, you see nucleus in the center. There are 2 possibilities. One possibility is this may be a regenerating fiber, right? Because regenerating fibers have internalized nuclei at some moment, let's say 3 weeks ago, 4 weeks ago, something like this. But if this is regenerating fiber, if they are regenerating fibers, all of them are regenerating fibers, right? They look all the same. So your patient should say that I had big problem 1 month ago, something like this, right? If this is all regenerative fibers, it means that all fibers were necrotized at the same time, right? But probably this is not the case because you see, again, endomygeal, it's not really a little bit pink, but actually there is fibrous tissue. So there is endomygeal fibrosis, right? So it means that this is not just 1 month disease. It's a chronic condition. And this is also, you can tell this also from fat infiltration. So this case has a chronic myopathic condition. So it's not just one-time necrotic event, right? So this is actually a congenital myopathy with myonuclei in the center of muscle fiber. This is called central nuclear myopathy. I don't go into the detail, but the central nuclear myopathy can be autosomal dominant, can be autosomal recessive. But interestingly, in addition to facial muscle involvement, often 1/3 of patients show ptosis. This is some difference from other congenital myopathy. Yes, like this. Okay. This is abnormal. Why? This is an artifact. So in the beginning, so previously, earlier today, as I mentioned, once the muscle is frozen, you should never, ever defrost the muscle. You should not defrost the muscle. But this is defrosted. Once defrosted and refrozen, will be like this. Now, how can you examine necrotic fiber, regenerative fiber? Impossible. Totally impossible, right? So handling the sample is very important. Another example is this one. You see a lot of holes, right? This is because, again, this is artifact. This is improper freezing. Or, as I mentioned, the sample, after biopsy, the sample should be wrapped with wet gauze. But this gauze should not be very wet, right? If it is too wet, muscle will absorb water and will have this type of holes, right? So, muscle biopsy and muscle sample fixation are not difficult at all. But if you do it in the wrong way, you immediately get artifact. Always get artifact. So you have to do correctly for all the steps. How about, artifacts are irreversible. To avoid artifacts, there is only one way to avoid artifacts, not to make it. This is the only way. Once you make it, you cannot do anything. Right? How about this one? This looks like, there are holes, similar, but not all fibers have it. Selective, right? Actually, if you do oil red O staining, which detects neutral lipids, you can see a lot of lipid droplets, increased lipid droplets. So this is actually lipid storage myopathy, one of the metabolic myopathy. But actually, well, of course, we always describe, lipid droplets are increased or not increased, normal, something like that. But there is always borderline, a gray zone, right? So when we were wondering if we should say this increased lipid droplets or a normal range, we always look at H&E actually. When we see holes on H&E, we describe it increased lipid storage. Otherwise, normal. Okay. This is so abnormal, right? You see a big hole within the myofiber, and there is basophilic amorphous material inside, right? This one as well. This one, 2 holes in the one myofiber. This is Pompe disease. Pompe disease. Pompe disease shows very unusual holes and vacuoles within the myofibers. And this is almost diagnostic. And if you look at the electron microscopy, there are a lot of glycogens here and there is big autophagic vacuoles. Actually, the mechanism of and also we routinely perform acid phosphatase staining as well. Acid phosphatase is one of lysosomal enzymes. So you can tell that all vacuoles are lysosomal in nature. So do you know what kind of So Pompe disease is a metabolic disease, metabolic myopathy. So what kind of enzyme is deficient? You know that? So, well, this is acid alpha glucosidase, but the name is okay. You don't have to know the exact name. But the point is, this is an enzyme which digests glycogen within the lysosome. This is the most important point. Do you know the process called autophagy? Autophagy is necessary to renew all the cytoplasm, the cells. So they randomly surround some part of cytoplasm and they digest surrounded area, okay? But actually, this is called autophagosome. Autophagosome itself doesn't have any digestive function. To digest the material engulfed, they need enzymes, digestive enzymes. How do they get it? They get all the enzymes from lysosome. Lysosome has 60 different enzymes, digestive enzymes. Because you randomly engulf, surround the cytoplasm, you don't know what kind of material you have, right? Of course, you have protein, you have lipid, you have glycogen, you have all types of different materials. And you have to digest everything, right? To digest everything, you need 60 different enzymes, okay? And one of them is, of course, to digest glycogen. This is acid alpha glucosidase, okay? So that's why once you engulf, but you don't have acid alpha glucosidase, that's why glycogen will be accumulated, will never be lost. That's why you have big vacuoles with glycogen inside, okay? And lysosomes try to, work hard to do something, but they cannot compensate at all. That's why the other lysosomal enzymatic activity is upregulated, because they want to, they try hard, but it still doesn't work. So that's why acid phosphatase, very strikingly high. And if you do the PAS, you can tell that they are glycogen, right? Glycogen is accumulated within the vacuoles. Okay, and in the infantile form, the vacuoles are seen in virtually all fibers. In childhood form, in selective fibers. But in adult onset form, sometimes you don't see any vacuoles. So in adult onset, Pompe diseases are well known that, many people say that it is difficult to make a diagnosis of adult onset Pompe disease. Yes, and even clinically, because they show proximal muscle weakness and atrophy, but not really specific features. Yes, and even on muscle pathology, sometimes we don't see typical vacuoles. In this particular case, we see a little bit of vacuole, but I don't think this is the same. They are the same vacuoles. Another type of vacuole is here. This is also, it looks like artifacts actually. So if you have, if your fixation was poor, I don't think you can make a diagnosis of this one, because the vacuole themselves look like, artifacts. This is actually one of the glycogenosis, debranching enzyme deficiency. And again, if you do PAS, they actually, within the vacuoles, glycogen, you can prove that glycogen is accumulated. Then I will go into the interstitium. Okay, so again, to describe fibrosis, you have to look at the endomysium. Okay, this is endomysial fibrosis. But sometimes people, to indicate fibrosis, sometimes people say that interstitium is widened. Yes, interstitium is widened. But widening interstitium doesn't necessarily mean fibrosis. Because, for example, this one is widened. But this is not fibrous tissue, because something here is totally different from fibrous tissue. They are somehow amorphous. They are actually serum or plasma. And you can see a little bit of lymphocyte infiltration. Actually, this is edema, myoedema. And this is a case from myositis. Okay? And endomyelial fibrosis is more clearly seen in modified Gomori trichrome. You can see more green color, right? So when I'm really not sure whether there is endomyelial fibrosis or not, I always check modified Gomori trichrome because this is more sensitive. Okay, I'd like to discuss this case. So what do you think about the diagnosis? So in like 20 years ago, whenever we see this type of pathology, we made a diagnosis of myositis. And if there is no skin rash, we said polymyositis. But this is not the case. We already know the diagnosis. This case is limb-girdle muscular dystrophy. Okay? So then why we were misled? Because of this, for sure, right? But look at them. They are lymphocytes. Where are they located? Of course, surrounding the blood vessel, but where's the site location? We learned endomysium and perimysium. They are perimysium, right? Within the perimysium. So perimysial mononuclear cells, non-diagnostic at all. Of course, we describe it, but never diagnostic, okay? This one. And if you look at them, this more carefully, there are necrotic fibers and regenerating fibers, right? So lymphocytes are like human beings. So if you have necrosis, it's like a traffic accident or fire, so people will come and see, right? I'm sure Vietnamese also, if you have traffic accident, you will come and see, right? I think everybody does this. So this is reactive lymphocyte infiltration. They're exactly the same, they just come and see, okay? But this is limb-girdle muscular. And in dermatomyositis, often they say that there are perivascular cuffing or lymphocyte infiltration, but this is, again, non-specific. Of course, we often see it, but not diagnostic at all. This is not diagnostic. But the only diagnostic lymphocyte infiltration is this one. What's the difference with the previous one? Yes, exactly. The location is different. Lymphocytes are present between myofibers, endomysium. That's why I said that endomysium, perimysium, fascicle, they are the most important. They are present in the endomysium. So this is like a peaceful residential area where you live, right? And your house is surrounded by lymphocytes. And look at this guy. They are already in your living room, right? So these lymphocytes are totally different from people just come and see traffic accident. Not totally different. They are really bad guys, right? They have bad intention clearly, right? So this is the only diagnostic lymphocyte infiltration pattern. And this is actually the current pathological diagnostic criteria of polymyositis. Okay, this is another example. Endomysial lymphocyte infiltration surrounding and even sometimes invading into non-necrotic fiber. Because if it is necrotic fiber, it's like traffic accident. They will come and see. But this is not necrotic, but they come, surround, and invade. So they are really bad guys, right? So endomysial lymphocyte infiltration surrounding non-necrotic fibers or even invading into myofiber. This is really diagnostic. Finding of polymyositis, so it means that lymphocytes are attacking myofibers, right? And if you do immunohistochemistry, almost all lymphocytes express CD8. CD8 is the marker of cytotoxic T cells. Really, this is really toxic to myofiber, right? So it means that current, pathological definition of polymyositis is the disease where cytotoxic T cells attack normal-looking myofiber. This is the current definition, pathological definition of polymyositis. Okay, again, the same, right? This. So polymyositis, current polymyositis, the definition is cytotoxic T cells attack necrotic myofiber. But you have to be careful. In addition to this finding, if you have rim vacuoles, or I don't go into the detail, but the same phenomenon, earlier phenomenon of the rim vacuole, formation, you have P62 or TDP43 aggregates. So they are the same phenomenon actually. So if you have this type of phenomenon, in addition to polymyositis type, lymphocyte infiltration, diagnosis will become inclusion polymyositis. And there are a number of papers saying that pathologically diagnosed cases diagnosed as polymyositis, almost all cases later develop IBM, inclusion polymyositis. So now increasing, more and more muscle pathologists believe that there is no polymyositis. At least pathologically defined polymyositis does not exist. That's what many people now believe. Okay, I'll skip this one. And actually, this was published like 5 years ago. The European groups studied using unsupervised analysis. So they found that there are 4 clusters of myositis: dermatomyositis, inclusion body myositis, immune-mediated necrotizing myopathy, and antisynthesis syndrome, but there is no polymyositis. So now many people, increasing number of people believe that there is at least no polymyositis, at least pathologically defined polymyositis does not exist. But lymphocytes surrounding the blood vessel were sometimes abnormal, okay? Not always non-specific. What's the difference? Look at the vessel. Vessel is abnormal. Vessel wall is abnormal. This is fibrinoid necrosis. Of course, this is a small vessel vasculitis. So, of course, lymphocytes are surrounding the blood vessel, but the vessel wall itself is different. So if vessel wall is abnormal, you should think about vasculitis. Okay, that's all for H&E. And modified Gomery trichrome is actually special staining, because H&E is in a sense everything, but H&E unfortunately cannot pick up everything. So something you have to pick up on modified Gomery trichrome has certain names like nemaline body, cytoplasmic body, tubular aggregates, rim vacuole, red fibers. So some specific findings, some specific structure can be identified by modified Gomery trichrome. Okay. So this one, they are nemaline bodies. That's why this is called nemaline myopathy. Nemaline myopathy. And I will skip this one. And nemaline myopathy actually is usually congenital myopathy. There are at least 11 different causative genes have been identified. But you have to be careful. There is an acquired form of nemaline myopathy. And around half of them are M protein positive, okay? Nemaline myopathy patients, congenital form often affects facial muscle, as you just learned from Dr. Umapathi. And the most severe case has very elongated face because of facial muscle involvement. But important one is they have narrow high arched palate, not just high, narrow high arched palate. And of course, this is not from that lady. This mouth is from not that lady, right? You can tell from the hair here. This is a guy. Yeah. Actually, this is a 28-year-old man. And he was introduced me after I gave a lecture in Bangkok. And he was brought on the wheelchair next to the podium. Of course, I can't examine, I can just see briefly examine patients because it's not a clinic. And he was introduced to me as a patient with distal myopathy, okay? And he said that, okay, onset is around 18 years, like 10 years ago, and he stopped walking like 2 years ago, 26, and he was 28. So that's all I heard. And I don't remember CK, but not very much elevated. And yes, his legs are thin. Distal legs are more thinner than proximal legs. So that's why they call it distal myopathy. But if I look at his mouth, I immediately mentioned that, he must have congenital myopathy, maybe nemaline myopathy. And indeed, he had nemaline myopathy. So as Dr. Umapathi mentioned, looking at mouth is very important. In a busy clinic, I think you sometimes skip it, but you have to really look at it. This may help. Okay, I'll skip this one. And yes, this one, sporadic late onset nemaline myopathy. There are some, adult onset acquired nemaline myopathy. And half of them are M proteinemia positive. This is very important especially for pathologists, because you can see nemaline bodies, but they are really small. Often they are very small. Like we call it sand-like because it's very small. Yeah, like this, sand-like. And some papers said that M proteinemia positive cases, they die within several years. All cases die without treatment if you don't treat them. But if you treat them, almost all patients survive and can even return to normal life. So, depending on whether muscle pathologists can make a correct diagnosis or not, patients, the outcome is completely opposite. Patient will die or return to normal life. Completely opposite, right? So the muscle pathologist responsibility is very big for this one, or even though it's rare. This particular case, so one paper suggests that, of course, there's no standard treatment protocol, but one paper suggests, because M proteinemia is typically seen in multiple myeloma, so they follow the protocol of multiple myeloma treatment. So they used peripheral blood stem cell transplantation, yes, right? So then before this, he couldn't raise his head. But after this, right, normalized, and he returned to normal life. So this is very important condition you should know. And cytoplasmic body, you can see they are actually abnormal protein aggregates. And if you look at you can also see something green as well. They are called spheroid bodies. So spheroid bodies and cytoplasmic bodies, they are produced by abnormal protein aggregates. And if you see many of them, this is more striking, right? If you see many of them, actually the diagnosis is myofibrillar myopathy. I list up only 6 genes which are identified in early period, but the list is much longer now. And among them, this is very interesting. Cytoplasmic bodies are aligned like necklace at the periphery of the myofiber. This pattern, we named it necklace cytoplasmic body. So this necklace cytoplasmic body can be found only in one disease, which is hereditary myopathy with early respiratory failure. So as its name suggests, patients develop respiratory failure early, even while they are still ambulant, while they are still walking. And this is caused by mutation in titin gene, in one specific exon. Titin has 363 exons, a lot of them. This is one of the highest number of the exons, yes. But and this particular disease is caused by mutation in exon 143, nothing else, yes. But even muscle pathology can tell the mutation. They are called rim vacuoles. You can see empty space surrounded by the rim. Yes, then they are called, that's why this is called rim vacuoles. But actually this is an artifact. If you look at this one, you can see a lot of red-colored granules, collection of red-colored granules. Actually, when you make pathology slides, actually the part of this collection of the granules will detach from slide glass. And that's why you will have empty space. But at the periphery, you still have this one, okay? And in fact, if you look at the electron microscopy, there is no empty space like that. And what you see is a lot of autophagic vacuoles and often surrounding some kind of protein aggregates. So most likely, though the protein aggregates are present, then autophagy is induced to clean up those protein aggregates, but they can't. That's why autophagic vacuoles are accumulated like this. And this part is detached from the slide glass, and the periphery is still there. This is rim vacuole. One of the most typical disease which shows rim vacuole is GNA myopathy. There are Vietnamese patients, I know, so I think this is also important for you. And you can see the tibialis anterior muscles are preferentially affected, while quadriceps muscles are relatively spared. And there is no cure, but actually we just finished the clinical trial and for sialic acid supplementation therapy, and the pharmaceutical company just submitted the new drug application, and hopefully it will be available within 1 year. Okay, but the rim vacuoles are not really specific to GNA myopathy, but can be seen in a wide variety of conditions, including inclusion body myositis, as I mentioned earlier. This is ragged red fiber. They are ragged red fibers, and of course this is seen. They are seen in mitochondrial disorders like CPO, MRF, or Miller's. They are tubular aggregates. Tubular aggregates are believed to be derived from sarcoplasmic reticulum. And if you look at the electron microscopy, you can see this collection of tubular structures. That's why this is called tubular aggregates. And then intramuscular nerve, they have myelin, right? And myelin are beautifully demonstrated by modified Gomery trichrome. But in neuropathic conditions, in motor nerve, those myelinated fibers are decreased in number. NADH TR, actually, this oxidative activity is seen in sarcoplasmic reticulum, T-tubules, mitochondria, and lysosomes. But we do acid phosphatase for lysosomes. We do SDH and COX for mitochondria. So most important one is sarcoplasmic reticulum. Where are those sarcoplasmic reticulum present? Actually, sarcoplasmic reticulum surrounds each myofibril. Actually, in one myofiber, there are 200 to 300 myofibrils. And each myofibrils are composed of actin and myosin. So they slide with each other. So this is the contraction unit. And each myofibril is surrounded by this type of bag-like structure. This is actually the sarcoplasmic reticulum. So sarcoplasmic reticulum surrounds each myofibril. This is a very important concept. So look at this one. So NADH stains each sarcoplasmic reticulum. So that's why not myofibril, but the surrounding area is highlighted like a meshwork, right? So this is why this is called intermyofibrillar network. So NADH-TR is to show the, to illustrate the alignment of myofibrils indirectly by by the intermyofibrillar network. Yes. So this one is just to visualize intermyofibrillar network, and there are many names. Like, for example, this one is called lobulated fiber. And lobulated fibers themselves are not very specific, but some type of limb-girdle muscular dystrophy are known to show lobulated fibers almost always. That is limb-girdle muscular dystrophy, R1 or 2A, or calpainopathy. Yes, in calpainopathy, in the advanced stage, lobulated fibers are always present, but can also be seen in other conditions. In other conditions, not always. Well, maybe I don't go into the details, but I think the LGMD nomenclature is a little bit complicated now. So I will skip this one. Yeah, okay, so this one called moth-eaten fiber or moth-eaten appearance. This is very famous nomenclature, but non-specific at all. This doesn't help to make a diagnosis at all. You remember this one, right? This is central core disease, okay? Central core disease is very interesting. If you look at electron microscope, of course you have myofibrils, but NADH negative. It means that you don't have sarcoplasmic reticulum, right? And you don't have mitochondria. Actually, cytoplasmic reticulum, you have calcium. And each time when you receive signal from motor neuron, calcium is released from sarcoplasmic reticulum. Without this, you can't make stretch, right? You can make contraction. And also, no mitochondria means no ATP. So you, of course, again, you can make contraction here. So it means that probably in central core disease, core part, no contraction. Only the peripheral part show contraction like this. And that's why probably patients have, difficulty, moving their body. This is actually caused by RYR1 gene. Yes. RYR1, ryanodine receptor, do you know where they are located? Actually, this is the calcium channel on sarcoplasmic reticulum. So as I mentioned, I said, every time calcium is released from sarcoplasmic reticulum, this channel is RYR1, okay? And why it is called receptor? Because ryanodine is actually a poison. Actually interacts with this receptor. That's why pharmacologically this was initially named as ryanodine receptor. But this is totally different from like a neurotransmitter receptor or something, okay? All right. And these patients often have this type of scoliosis. So sometimes orthopedic surgeon ask us to check muscle when do surgery for scoliosis patients. And sometimes we find central core disease in those cases. How about this one? They look very abnormal. I already talked about it. You see, the pattern network, you don't see any network. Empty space at the periphery of myofiber. This is called peripheral halo. Empty space is peripheral halo. This is almost diagnostic of myotubular myopathy, X-linked myotubular myopathy. And this is the muscle from very young patient, like few months old. And X-linked myotubular myopathy is cause mutation in myotubular ring gene, and patients are usually very, very sick. Yeah, very sick, like frog-like posture. Well, I will skip this one. And then this one is called targetoid fiber. It looks very similar to central core, but looks dirty, right? And we still don't know the exact mechanism of the target or formation or central core formation, but some people believe that maybe the basic mechanism is very similar. But if you look at this very carefully, there is actually group atrophy, large group atrophy and small group atrophy. And this is neurogenic condition. So targetoid fibers themselves are not very specific, but if you see many of them, most likely your diagnosis is neurogenic condition. And in the center of target fibers, you often see this type of spheroid body. Yeah, this is called spheroid body. And I talked about tubular aggregates on modified Gomery trichome. Tubular aggregates are derived from sarcoplasmic reticulum. And NADH activity is seen is present in sarcoplasmic reticulum. That's why tubular aggregates are highlighted by NADH. Okay, lastly, I will go through myosin ATPase. Myosin ATPase is just to differentiate fiber types. There are 3 fiber types in normal muscle fiber, type 1, 2A, and 2B. Okay? So abnormality may be just type 1 is atrophic. You can see type 1 fiber atrophy, or just type 2B is atrophy, type 2 is atrophy, then type 2 fiber atrophy. Or maybe the pattern is abnormal. If you read the textbook, they say that the composition is 1/3, 1/3, 1/3, and they are present in a checkerboard pattern or mosaic pattern. But if you have a lot of type 1 fiber, for example, this is called type 1 fiber predominance, and in one area only type 1 or type 2 fibers are clustered, this is also pattern is abnormal. This is called fiber type grouping. And sometimes one fiber type is deficient. Often this is type 2B fiber, but so type 2B fiber deficiency. That is all abnormality. And finally, there is another fiber type called type 2C. This is abnormal type fiber type. So then how can we differentiate? Okay, so type 1 fiber and type 2 fibers, they have different property. So the activity, myosin ATPase in type 1 fibers are inactivated in alkaline conditions. So if you incubate the specimen for a while in alkaline condition like 10 point something, then type 1 fiber in the myosin ATPase in type 1 fiber atrophy, so type 1 fiber will be completely inactivated. That's why only type 2B fibers are highlighted, or you can see the color. And this will be completely opposite. So in acidic condition, type 2 fiber, the myosin ATPase in type 2 fibers will be lost, inactivated. That's why only type 1 fiber is stained. Okay? Then you increase a little bit, pH a little bit, then only type 2B fibers show intermediate color. This is how we differentiate each fiber type. Okay, so then I will go through the abnormality. So one possibility is type 2 fiber atrophy. Type 2 fiber atrophy is non-specific. You can see aging process, malnutrition, or sarcopenia, or whatever. But this is not really muscle disease. For example, this one, all type 2 fibers are very much atrophic. Of course, this is, I don't say this is normal, but this is not muscle disease at all. Non-specific change. But in contrast, type 1 fiber atrophy is very important. Almost always muscle disease. Type 1 fibers is actually anti-gravity muscle or red muscle. So if your patient says that he or she went to moon or space last week, then anti-gravity muscles will become atrophic, right? But I don't think your patients go to the moon, right? So it means myopathic. If you see type 1 fiber atrophy, myopathic. So this is completely opposite to type 2 fiber atrophy. For example, this one, you see nemaline bodies. Although these nemaline bodies are a little bit smaller, but still they are nemaline bodies. So if you look at ATPase, you know, most of the fibers are type 1, right? So clearly there is type 1 fiber predominance. And of course there are big ones, but all small ones are type 1. So there are type 1 fiber atrophy and type 1 fiber predominance. And in many congenital myopathies, you almost always see type 1 fiber atrophy and type 1 fiber predominance, okay? Even in nemaline myopathy. But look at this one. But even on modified Gomery trichomy, you can somehow tell darkly stained one is type 1 and faintly stained one is type 2. And you don't see any nemaline bodies. But look at this one. Pattern is very similar. Type 1 fiber atrophy, and the number of type 1 fibers are way, more than type 2 fibers. So there is type 1 fiber atrophy and type one fiber predominance, just like nemaline myopathy, but without nemaline bodies. This condition is called congenital fiber type disproportion, or CFTD. And if you look at the ATPase, see type 1 fibers are smaller and more type 1 fibers. And in this particular fascicles, type 2B fiber is deficient, right? And this is CFTD as well. And interestingly, most of the CFTD cases are clinically very similar to nemaline myopathy. And in fact, most of the causative genes so far identified for CFTD are actually exactly the same as nemaline myopathy, right? So you may wonder how many nemaline bodies, how many fibers with nemaline bodies are required for the diagnosis of nemaline myopathy. Interestingly, some cases have show, almost all fibers show nemaline bodies. Some cases 50%, some cases 10%, some cases 1%, some cases only 3 fibers with nemaline bodies, some cases only 1 fiber. Then maybe some cases 0. And so probably CFT, when you don't find any nemaline bodies, it is called CFTD. But probably they are the same disease, right? So if you don't see nemaline bodies, it is called CFTD. This is central nuclear myopathy. Again, the same. You see a lot of type 1 fibers and type 1 fiber atrophy. They're exactly the same. And finally, I'd like to discuss type 2C fibers. Type 2C fibers is undifferentiated or immature fibers. So of course, if you have a chance to see fetal muscle from the fetus, of course, many of them are type 2C fibers. And regenerating fibers, they are immature, of course, type 2C fibers. And in addition, you also see type 2C fibers in neurogenic condition. I will tell you why. So to understand this one, you need to know who determines the fiber type. Okay, as I mentioned, there are 3 fiber types, type 1, 2A, and 2B, 3 fiber types. Who is the one which determines the fiber type? So each myofiber said that I want to be type 1 or I want to be 2A or like this? No, actually. Actually, the motor nerve or anterior horn cells determines the fiber type. So if the one myofiber is, innervated by type 1 motor neuron, it will become type 1 fiber. If it is innervated by type 2A motor neuron, it will become type 2A. Okay? So this is the very important concept. So when myofiber is made, in the beginning, they are like a single nuclear cell. So mononuclear cell, they are called myoblasts. They fuse with each other, then they become myotube. But when myotubes, before innervation, they don't know what to be. Because before innervation, they don't know which fiber type they have to be. So once innervated, now they received order. You have to be type 1 or you have to be 2A, right? And finally, they become maturated. So until this point, at all stages, they are immature. This is called type 2C fiber, okay? And after innervation, now they become type 1 and type 2. This is from Duchenne muscular dystrophy. Of course, there are many type 2C fibers. Then practically, how can we know which one is type 2C fibers? So if you remember, normal type 1 or type 2 are inactivated at alkaline or acidic condition. It means that should be white in acidic or alkaline condition. But type 2C fibers are always stained, even in acidic or alkaline condition. For example, this one, type 2C, stained, always stained, right? So this is type 2C. But actually, the fiber across the street also type 2C, stained. This is faint, but still stained. So this is type 2C. Actually, next door here, this is also type 2C, stained. right? So there are many type 2C fibers. This is a matter of course because there are many regenerating fibers. Finally, this is more important. Type 2C fibers can be seen in neurogenic condition, as I mentioned. Why? The distribution is very abnormal, right? In this area, all fibers are type 1. This is called fiber type grouping. Fiber type grouping, if you see fiber type grouping, you can tell that there was a re-innervating process, re-innervation. And whenever you see re-innervation or fiber type grouping, you always see 1 or 2 type 2C fibers. I will show another example. This is remarkable fiber type grouping, right? The type 2, type 1, but still you can see a lot of type 1, type 2C fibers, intermediate column. They are all type 2C fibers. This is another example of type 2 fiber type grouping. Why we can say that fiber type grouping reflects re-innervation? I will tell you why. So as I mentioned, if myofiber is innervated by type 1 motor neuron, it becomes type 1, right? So one day, there was a denervation like this, okay? The first thing happens is now those fibers don't know what to be, right? No signal anymore. So they become type 2C fibers, first of all, right? And if there is nothing happens, they will be atrophied and small angular fibers. But normally, this survived fiber try to rescue them by making new branch. This is called sprouting, right? Then what's going to happen? All those fibers are now under him, right? That's why all areas become the same fiber type. This is called fiber type grouping. So this reflects sprouting re-innervation. But always some fibers are a little bit far from branching point. That's why you always see 1 or 2 type 2C fibers. Yes. This is what we see on ATPase. Okay. Well, there are other histochemical stains like SDH, COX. They are mitochondrial enzymes. Phosphorylase and phosphofructinase, they are deficient when you have myocardial disease or thyroid disease. Acid phosphatase I already discussed. Well, SDH is a complex 2 mitochondrial disease, mitochondrial enzyme. I will skip this one. Yep. I want to, I talked about rugged red fiber on modified Gomery trichome, but SDH is more sensitive, so you can pick up more rugged red fibers. And another important one is sometimes vessel show high SDH activity. This is called strongly SDH reactive vessel, SSV, and typically seen in MELAS. MELAS patients have stroke-like episodes, right? Maybe related to vessel abnormality. And cyclomacy oxidase, like Lee syndrome, sometimes you see this type of total COX deficiency. But more in adults, we often see focal COX deficiency like this. When we see focal COX deficiency, you can immediately say that in this myofiber, there is mitochondrial mutation. This is called mitochondrial DNA mutation, mitochondrial DNA abnormality. Why we can say that? And often SDH highlighted, the rugged red fiber is COX negative. And if you do COX SDH double staining, they look blue. So some people call it rugged blue fibers. Okay. Then why? COX deficiency indicates mitochondrial DNA mutation. So this illustrates, there are 5 respiratory chain enzymes, complex 1 to 5, and they are composed of mitochondrial DNA encoded protein and nuclear DNA encoded proteins. Like, and SDH is complex 2 and COX is complex 4. Look at this one. You see the here nuclear encoded subunits are highlighted in blue. And mitochondrial DNA encoded one is pink. Look at this one. SDH, only SDH is composed by nuclear DNA encoded protein. But COX is composed of both. So if you have mitochondrial DNA abnormality, these are affected, but SDH are not affected, right? This is why SDH is highlighted, darkly stained, while COX activity is lost. You know the mitochondrial DNA, well, in one cell, there are several thousand to 10,000 mitochondrial DNA. And when you have mutation in mitochondrial DNA, usually not all 10,000 mitochondrial DNA have mutations, only some of them, okay? So let's think about it. So if you have all of the mitochondrial DNA are mutant, of course, probably COX activity is 0, right? But of course, if it is 0%, all of them are normal one, of course, COX activity is normal. So what is the relationship between this one? Actually, this is not like this. This is like this. And, all of a sudden, this will become 0. This is called threshold effect. And for example, in CPEO, this is around 60%. But in ragged red fiber, usually this is more than 90%. That's why in ragged red fibers, COX activity is completely 0. Okay? So it means that if you see COX negative focal, so in some fibers, COX is positive, in some fibers, COX negative, depending on the percentage of mutant mitochondrial DNA. Okay? So that's why if you see focal COX deficiency, you can tell that this is because of mutant mitochondrial DNA. And in MELAS, typically we see SSV and ragged red fibers are COX positive or negative because actually in MELAS, threshold is around 90%. So that's why this curve like this. So some ragged red fibers COX positive, some are negative, like this. But in CPO, that is 60%. So that's why all ragged red fibers are COX negative. Okay. And then we do immunohistochemistry for muscular dystrophy and also myositis. Yeah, so this is a set of muscular dystrophy. I don't go into the detail, for example, dystrophin is absent in Duchenne muscular dystrophy. This is how we make a diagnosis. And for immunohistochemistry, we do this set. Okay, so this is the last slide. So in the beginning, I talked about muscle biopsy and staining, the fixation. And the histochemical staining, those three are the most important, especially H&E. And lastly, I discussed ATPase, myosin ATPase. This is to differentiate each fiber type. And especially fiber type grouping indicates neurogenic, more specifically neurogenic, the re-innervation after sprouting. Okay, that's all. Thank you. Yeah, so if you have any question, I'm happy to take.
Thank you for your presentation. I have a question.
As you mentioned, there are several special states for the muscle biopsy. But in my country, we cannot perform all the work. We know that three methods is most important. That's ALE, Gomori, and NSDA. But how we choose the right special state for each disease group
Yes, that is a very important question for in a place where you want to establish the system. Yes, I don't think you can have everything from the beginning. It's very important. So you have to be selective, of course. But at least you should do HNE, modified Gomery trichomer, and NADH, and ATPS. Then I think you should add more and more as much as you can. And probably the next one you may want to add is SDH and COX, right? And other enzyme histochemistry, yes, right. But eventually, again, if this is a tertiary hospital, and probably this is one of the biggest hospital in the country, right? So last defensive line. So I think you should do everything you can do, yes. But of course, from the beginning, it's very difficult. But eventually, you should try to do everything.
Okay. So you mentioned in the first section, you mentioned about in the HNE section, you're mentioning about the vacuolar changes. And later on, you're talking about the lysosomal autophagic vacuoles. Could you explain that part a bit more in terms of the differentiate vacuolar changes that are autophagic versus non-autophagic?
Yes. So Pompe disease, I think their vacuoles are very unique. So except for adult onset cases, you will not miss the diagnosis. It's very unique, right? And they are highlighted by acid phosphatase. But other autophagic vacuoles are often small in size. So if the specimen, the condition of your specimen is poor, you may miss it actually. And I didn't show it, but for example, the disease called Danon disease, they have really small, tiny autophagic vacuoles. So often in many laboratories, those vacuoles are overlooked, really overlooked, because they are really tiny. And for non-lysosomal vacuoles like glycogenosis, now they usually have big vacuoles. Yes. But the problem is, again, if the sample condition is poor, they look like artifacts, and it's almost impossible to differentiate from artifacts to the real vacuoles. That is the problem. Yeah. So, yeah.
So the autophagic vacuoles are more likely to be rim vacuoles.
Well, it's a bit tricky. Yeah, rim vacuoles, yes. If you do, actually rim vacuoles, again, as I mentioned, the rim vacuoles are made to scavenge actually the protein aggregates. So probably P62, if you do immunohistochemistry, like P62 will be more sensitive and more reliable because rim vacuoles are artifacts by nature. So sometimes you don't see rim and you cannot be so sure. But P62 aggregates are more clear and yes, too easy to identify. And other lysosomal vacuoles like Danon disease, we don't see P62 aggregates, but can be highlighted by LC3, like autophagic vacuole, autophagic marker. So I think probably the mechanism is different for rim vacuole and also the Danon disease or others. Yes.
I have a question. With type 2 fiber atrophy, you said that it's not specific, but it's also called the weakness of patient, right? Muscle fiber atrophy, type 2 atrophy. But for example, if patient will have a stroke or something like this, they can have type 2 fiber atrophy. Do you think it can cause the reductions of combo muscle action potential when we do nerve conduction study?
Well, whenever you have muscle fiber atrophy, of course, MUP will be decreased. The amplitude will be decreased, whatever the reason is. So even if it is type 1 fiber atrophy, type 2 fiber atrophy, if you have muscle atrophy, fiber atrophy, I think the MUP will be decreased. I don't think you can differentiate by nerve conduction study or even EMG. Yes.
Dạ, anh chị nào có câu hỏi với thầy nữa không?
Again, thank you.
Dạ, thì chúng ta đã kết thúc cái phiên sáng nay. Thì em tin chắc rằng là cái bài vừa rồi của thầy Nishino thì thầy có yêu cầu là ngay từ ban đầu là không có phiên dịch, cho nên là em nghĩ rằng là mặc dù thầy có ngay từ đầu thì có nói bài rất là căn bản thôi, nhưng em nghĩ rằng là nó cũng sẽ khó đối với một số các bác sĩ giải phẫu bệnh chứ không có riêng gì các bác sĩ thần kinh. Tuy nhiên các anh chị yên tâm là những cái bài này bọn em có thực hiện ghi hình, cho nên là sau khi ghi hình xong thì bọn em sẽ đăng tải các cái bài đã ghi hình này lên cái QR code này, cái phần tài liệu này. Là cái thứ nhất. Cái thứ hai thì bây giờ chúng ta tới giờ nghỉ trưa, chúng ta sẽ đi ăn trưa tới 2 giờ chúng ta quay lại. Thì chiều nay chúng ta làm gì? Thứ nhất thì trong lúc các bác sĩ giải phẫu bệnh và bác sĩ thần kinh chúng ta ngồi học ở đây thì các anh chị kỹ thuật viên đã được anh Minh, kỹ thuật viên trưởng của bộ môn đã có những cái hướng dẫn căn bản ở lúc nãy. Thì chiều nay chúng ta sẽ bước vào phần thực hành. Thì trong cái phần thực hành chiều nay chúng ta sẽ chia thành 2 nhóm, và cái người thực hiện chính vẫn là các kỹ thuật viên mà thôi. Các bác sĩ sẽ đứng ngoài và quan sát, có thể là một số bác sĩ giải phẫu bệnh thì có thể cho lên cùng, và sau đó chúng ta sẽ thực tập theo vòng. Thì chiều nay các thầy sẽ quan sát cái cách thức mà các kỹ thuật viên làm. Chúng ta sẽ luyện tập cái cách làm sao để sinh thiết đúng, làm sao để bảo quản đúng, rồi sau đó là em có nghe nói là kể cả thực hành nhuộm căn bản nữa, và sau đó thầy sẽ phản hồi lại là cái mẫu đó và cái cách thức làm như vậy đã đạt hay chưa đạt. Cả hai thầy sẽ làm cái việc đó, và đây cũng là một cái điểm rất là thú vị trong cái workshop lần này, và chúng ta sẽ bắt đầu vào lúc 2 giờ chiều nay. Em cũng xin nhắc lại là một số anh chị có đăng ký cái CME ấy, thì để cấp được cái CME thì em cũng đề nghị là trong chiều nay bọn em sẽ cho cái QR code lên cái slide này, thì các anh chị phải làm cái CME và các anh chị phải hoàn thành thì nhà trường mới cấp CME được. Thì chiều nay thì em sẽ đặt cái QR code đó để mọi người có thể quét được. Trong sáng nay thì cũng là một cái buổi cũng rất là hay, là cái buổi trình ca lâm sàng. Thì cái buổi sáng mai thì bọn em đã
So case prevention is tomorrow?
bao gồm cả lâm sàng, và sau khi
this is for tomorrow.
xong thì chúng ta sẽ qua trực tiếp cái phòng bên này để thực tập động các cái mẫu sinh thiết. Thì cái buổi ngày mai thì cũng khá là lý thú, đâu đó khoảng 3 ca. Dạ. Thì bây giờ là chúng ta nghỉ trưa cho tới 2 giờ chúng ta quay lại. Dạ. Xin chào mọi người và hẹn gặp lại.